Welcome to 2026 HIRA International Symposium. I am Park Se-jung, and I will be your MC for today's conference.
Good morning, everyone, and welcome to HIRA International Symposium 2026. My name is Park Se-jung, and I'll be your host for today's event. First of all, thank you very much for joining us today. Your presence is making this symposium even more meaningful, and I'm truly honored to be here as the host for this meaningful event. 이른 아침부터 귀한
Thank you once again for joining us early in the morning, despite your busy schedule. And also, I'm very honored to serve as an MC for today's symposium. The topic of today's symposium is the Great AI Transformation, Unlocking the Future of Healthcare Innovation, Reimagining Systems, Policies, and Practices. It brings together healthcare stakeholders and experts from Korea and around the world to explore key global healthcare issues and examine policy and technology trends across different countries.
Is the Great AI Transformation, unlocking the future of healthcare innovation, reimagining systems, policies, and practice. So we have invited a lot of professionals and representatives from these fields around the world, and in-depth discussions will be carried out. I hope you share great insights with us today. 자, 특히 의료 AI 기술과 또 보건의료 환경의 빠른 변화 속에서
So in the midst of the rapid advances in medical AI technology and the changing healthcare landscape, we have prepared a meaningful program to explore policy directions for integrating medical AI into the healthcare system and to share the latest healthcare policy and industry trends in Korea and abroad. So we hope you will stay with us throughout the symposium and share your feedback. And as I mentioned earlier, in support of carbon neutrality and our efforts to reduce paper use, we have not prepared printed materials for today's symposium. So for those joining us here in person, you will see the two QR codes on the screen, one to download the symposium material and the other to participate in a survey for today's symposium. And those who complete the survey will also have a chance to receive a coffee voucher through a prize draw. So we encourage you to participate. Today's symposium is also being live streamed on our official YouTube channel. So for those joining us online, please use the link below the live stream to access the symposium material. Now, to kick off today's program, we would like to hear the opening remarks. So for this, we would like to invite the President Seungkwon of HIRA for his opening remarks. Please welcome him with a big hand.
Welcome to our symposium. Good morning, distinguished experts and esteemed colleagues from Korea and around the world. And welcome to our annual symposium. I am Seungkwon, President of HIRA. It's a great honor to host this symposium for the first time taking office as President of HIRA. First, I would like to sincerely thank you for all joining us at the 2026 HIRA International Symposium. I would also like to extend a particularly warm welcome to our international speakers and healthcare representatives who have traveled a long way to be with us today. AI is transforming the future of healthcare. It helps us predict disease and detect it earlier. It supports more personalized treatment, and it is improving the quality and efficiency of healthcare services. At the same time, the use of AI in healthcare has a direct impact on people's lives and health. This is why the principles and standards we establish and the institutions we build matter so much. For healthcare AI to develop in the right direction, policy, and institutions. Clinical practice, all this cannot move forward in isolation. Policy must reflect the need and realities of the clinical field. Institutions must support the safe, responsible, and effective use of new technologies. And practice, in turn, must feed the lessons and challenges from real-world use back into policy and institutions. When policy, institutions, and practice come together from the very beginning to discuss, design, and move forward, AI can become a healthcare innovation that truly earns public trust. This is why this symposium matters so much. I hope today's discussions will help shape the right direction for healthcare AI and mark a meaningful starting point for changes that people can truly experience in their everyday lives. HIRA will continue to play its part. We will work to connect policy, institutions, and practice in a responsible and meaningful way. Once again, thank you for being here today. I wish you all fruitful discussions and meaningful connections. Thank you.
네, 원장님 좋은 말씀 고맙습니다.
Thank you very much, President. As you mentioned, the AI will play a critical role in driving changes in healthcare and medical field. And I believe that AI will also be a driver for innovation in this field. So in this regard, I sincerely hope that today's symposium will be an opportunity for us to set the right directions for the future of AI. Now we would like to hear the congratulatory remarks. So we would like to invite the Mr. Hyung-hoon, Second Vice Minister of Health and Welfare, and we would like to watch his video. Good morning, distinguished guests, ladies and gentlemen. I am Lee Hyung-hoon, Second Vice Minister of Health and Welfare. I sincerely congratulate HIRA on hosting the 2026 International Symposium. My sincere thanks goes to the President Seungkwon, the organizer, and all the speakers and panelists from Korea and around the world. Artificial intelligence is an important policy tool for improving the quality of healthcare and providing better medical services to the public. For new technologies such as AI, in order to take root in clinical practice, we have to verify their safety and effectiveness, and we have to establish appropriate institutional frameworks for their practical use. This symposium brings together experts from the OECD, Australia, Denmark, and Taiwan, as well as Korean academics and government officials to discuss how AI can be integrated into healthcare systems and to explore the challenges of innovation in the field. The program begins with a keynote on how to safely expand the use of AI in healthcare, followed by presentations on policy challenges in integrating medical AI into existing systems. We'll also explore how healthcare regulatory agencies in Europe and Asia are actually using AI in practice. I hope this will be a meaningful opportunity to share experiences from around the world. HIRA's expertise and data capabilities in healthcare will play an important role in shaping policies and systems, and also to support and drive innovation in this field. The Ministry of Health and Welfare will continue to develop AI healthcare policies, and we will work to ensure that their benefits strengthen essential healthcare in local communities and improve public health. I hope the discussions and recommendations from this symposium will lead to meaningful and practical healthcare policies. Once again, thank you very much for your attendance.
박수 보내주실까요? 네,
Yes, thank you very much, Second Vice Minister, for your meaningful congratulatory message. Again, we have a number of distinguished National Assembly members who cannot be with us today but send congratulatory messages through video. Let's have a look at the NA members. Ki-hun, Man-hee, Young-seok, and Baek. Good morning, ladies and gentlemen. It's a pleasure to meet you. I am Ki-hun, Chairperson of the Science, ICT, Broadcasting, and Communication Committee of National Assembly. I'd like to extend my sincere congratulations on the opening of 2026 HIRA International Symposium. I'd like to thank HIRA President Seungkwon and all those involved in preparing this event. And I also extend a warm welcome to experts from home and abroad. HIRA International Symposium has been sharing healthcare policies and innovative practices from around the world since 2005. This year, it's particularly meaningful that we are discussing new directions for healthcare innovation under the theme of the Great AI Transformation, Unlocking the Future of Healthcare Innovation. AI is assisting healthcare professionals in clinical practice, supporting repetitive administrative tasks, and rapidly transforming the healthcare field. It will be an important means of improving the quality of healthcare and advancing innovation. However, medical AI, which deals with lives and health of people, cannot be fully realized through technological advancement alone. Its accuracy and safety must be thoroughly validated while protecting personal information and ensuring algorithmic accountability. It is essential to establish the institutional foundation needed to ensure that outstanding technologies can be successfully adopted in real-world settings. I hope that HIRA, with its expertise in reviewing medical expenses and evaluating the quality of healthcare, will objectively assess the reliability and value of medical AI and help lead the successful adoption. Furthermore, in Wonju, which has designated as an AI-specialized pilot city, I hope we can connect data and technology in the real-world setting. Representing Wonju, I will build a safe, trusted AI foundation and support it with sound policies. Once again, I extend my sincere congratulations on the opening of the symposium. I hope today's discussion will lead to healthier and safer everyday life for everyone. Thank you.
Good morning. I am Man-hee, Chairperson of the Health and Welfare Committee of the National Assembly. It is my great pleasure to congratulate you on the 2026 HIRA International Symposium, which brings together experts to discuss innovation across healthcare policies. My sincere thanks goes to the Seungkwon, President of HIRA, and all the healthcare experts from Korea and around the world for joining us today. AI-driven innovation in healthcare offers an important opportunity to address the challenges facing our healthcare system. Artificial intelligence can support early disease detection and personalized treatment while improving the quality of care and patient safety. It can also help reduce healthcare disparities across different regions and socioeconomic groups, and it also strengthens essential and regional healthcare services. Above all, technological progress must translate into meaningful improvement in public health, regardless of age, places of residence, or economic circumstances. Everyone should have access to safe and high-quality healthcare services. At the same time, we have to ensure the sustainability of healthcare insurance and the efficient use of healthcare resources. I hope this symposium will foster broad discussion on AI-driven innovation in healthcare services and healthcare policies from institutional and policy perspectives to practical application in clinical settings. Our committee will do its utmost effort to support legislation and policies, always putting the lives and safety of the people first. Once again, I congratulate you on the opening of this symposium, and I wish all participants good health and happiness. Thank you.
Good morning. I am Young-seok, a member of National Assembly and Secretary of the National Assembly Health and Welfare Committee. I would like to extend my sincere congratulations on the opening of the HIRA International Symposium 2026. I would like to express my deepest appreciation to President Seungkwon and everyone at HIRA for organizing this meaningful event. And to all the experts joining from home and abroad, I also extend my warmest welcome. Today's symposium is themed The Great AI Transformation Unlocking the Future of Healthcare Innovation. And the symposium provides a valuable opportunity to explore the transformation of healthcare through AI, share innovative cases from around the world, and discuss together the future of AI in healthcare and the challenges that lie ahead. AI is transforming every aspect of healthcare by improving the accuracy of diagnosis and treatment, supporting healthcare professionals, and enabling more patient-centered and personalized care. AI is becoming a key driver of innovation across the healthcare sector. Going forward, how we harness AI will have a profound impact on the competitiveness of our healthcare system and on the quality of care experienced by the public. The Digital Healthcare Act that I proposed is designed to establish an institutional framework for the safe use of healthcare data to improve the quality of care, strengthen essential public healthcare, and advance precision medicine, ultimately ensuring that these advances contribute to the health and well-being of the people. I believe that the healthcare data and expertise held by the Health Insurance Review and Assessment Service can also serve as a strong foundation for driving the transformation of healthcare through AI and advancing medical innovation that earns the public's trust. As Secretary of the Health and Welfare Committee and the Democratic Party of Korea, I will do my utmost through legislation and policy support to advance healthcare innovation suited to the AI era and create a digital healthcare environment. Thank you.
Good morning, ladies and gentlemen. I am Sun-hee Baek, a member of the National Assembly's Health and Welfare Committee, committed to building a happier welfare country for everyone. I would like to sincerely congratulate you on the 2026 HIRA International Symposium, and I would like to thank the HIRA President Seungkwon and all the experts from Korea and around the world. The true measure of AI innovation is not the speed of technological advancement, but how much it can improve the health and well-being of our people. Recently, I had an opportunity to see firsthand how medical AI is being used in clinical practice at Seoul National University Hospital, and I saw how AI is becoming a practical tool that improves the quality of healthcare, supporting the healthcare professionals. What matters now is to support these innovations through sound policies and strong institutional frameworks so that we can reduce healthcare disparities across regions and social groups to ensure no one is left behind. I will do my utmost to ensure that AI innovation leads to a stronger healthcare and social welfare safety net that benefits everyone. Thank you very much.
박수 보내주실.
Please, a warm round of applause. Thank you. Those were really kind, encouraging messages and congratulatory remarks from 4 National Assembly members. I would like to once again express my deepest gratitude. Before we get into the symposium's program in earnest, we're going to have a group photo taken. The stage is ready now. I would like to invite distinguished guests from home.
사진
So, once again, appreciate your active participation. And in German, you have also expressed on stage being a part of commemorative photo. In the morning, we will be listening to 2 keynote speeches, and in the afternoon, we will have 4 different presentations and a panel discussion. If your active engagement will greatly benefit the future policy making. Thank you. Okay, so we will start the morning program with the first keynote speech of the day, and it will be given by the senior health economist Sutherland from OECD, which is titled Scaling Fast While Doing No Harm, Incorporating AI in Healthcare System. Please welcome him with a big hand.
All good. Oh, yes. All good. I am truly humbled and honored to be here today. It is very difficult to follow the fantastic opening that we've had so far. So thank you so much. Thank you to HIRA and everyone who's involved in this whole event. The organization of it has been fantastic so far, and I'm really looking forward to the discussions that we're going to be having over the span of the day today. What I'm hoping to really emphasize is that the major challenges that we have to realize the AI future that many of our distinguished guests talked about earlier on is no longer the opportunity of building the actual technology itself. The problem that we have is how do we make sure that we can scale the technology in an effective and efficient way to reach every person who deserves, and everyone deserves to receive the benefit from the AI revolution that is upon us. So I'll start talking about who I am, but I will start by talking about what the OECD is, for those of you who do not know. This is the Organization for Economic Cooperation and Development. It's an organization that was formed more than 60 years ago. Korea was one of the early members to join in the overall evolution of the OECD as a global organization bringing together 38 leading countries around the world for literally what is in its title, for the economic cooperation of partners to work together to realize how we can develop opportunities by working together more effectively than by competing with each other across borders. My role at the OECD is really focused on the intersection of artificial intelligence, digital security, data and data governance, and their intersections with health. And importantly, how do we measure the progress that we are making with respect to the integration and better use of data, the better use of novel technologies such as artificial intelligence in our overall set of work. So that's my role. And frankly, how the world is doing, and one of the things that I get to do is I get to look at where all 38 countries are at, what their challenges are, and how to actually make progress going forward. Certainly, we're in a world where, with respect to digitalization and the adoption of AI and other emerging technologies, and I'll touch on that a little bit more later on, it is massively impactful in our health systems. It does not matter where you look in terms of the health journey, being a patient meeting with a doctor, be a patient going to an emergency room, trying to understand what the right public health interventions are that we want to have. Data and AI are everywhere in this system. I like to think of the data in our systems as the water that flows through, make sure that everything is, fed and nourished appropriately. The pipes of our system are the digital tools and technologies that carry the pipes to the right people in the right place. And then importantly, the AI systems, the novel innovations, are the taps that allow us to get the value out of those ecosystems. The problem that we have is that collection of pipes, water, and taps in many countries around the world are massively fragmented. When we first did the work in the digital age, in the span of the last 20, 30 years, we focused on the technology and we didn't focus on the data and the outcomes. And as a result, everyone wanted to build their own technology, they wanted to build their own data, and as a result, there were these silos that came up and were built all over the place. We're at a point now where we recognize that the integration of our data assets will enable us to find the insights with the tools like artificial intelligence going forward. But we need to really rethink our overall systems about how not we can do better with the technology, but how we can do better utilize the data for better health outcomes and how we can better integrate that data. When we integrate the data more effectively, the systems themselves will be more cost effective. We'll be able to more effectively scale, which I'll really touch on deeply in a second. And we'll also be more responsive to change, realize the opportunities from change, but also responsive to address the major issues as they arise. And ultimately, an integrated system ends up being lower risk and generates better outcomes. That sounds pretty good to your finance officers, the people who are the accountants in the room. I want to deliver more with less. If we use our data more effectively, if we realize the opportunities of AI more effectively, we can deliver more and better health outcomes for all with less resources ultimately. The problem that we have is that the work around artificial intelligence has such energy behind it that there is tension in the system. There is the forces of the market that want to move fast. An American expression, by the way, I just would like to clear this up. I'm Canadian, not American, in case there's any dispute around that. So as some American firms will say, we want to move fast and break things. The last thing we want to do in health is break anything. So we want to, however, learn how to move faster than we are right now. We have to balance that force against the forces of health, where we have the Hippocratic Oath that wants to first do no harm. We have to balance these things at the same time. And importantly, there is a third force, and this is the force that many countries, many organizations forget, based on what I heard earlier this morning. This is not a concern in Korea. Having said that, it is something to really embed in the practices of making sure that the value of this is achieved by everyone, that we're able to scale these solutions effectively. And that's why, as my little pin that I have on here says, we want to learn how to scale fast while doing no harm. And that is the overall mantra that we brought into the discussions at a conference that I ran at the end of May, where we had representations from around the world in order to really understand what we had to do in order to scale fast while doing no harm. The first thing that we've really reflected in this discussion is that there is a lot of noise. There is a lot of insights that are being published by many organizations, be it the think tanks. We have the World Health Organization, the OECD, the World Bank, APEC community. We have the G20 doing their own publications. And so all of these organizations are coming out, this is the way that we need to move forward with respect to AI. And the problem is when bureaucrats, when ministries of health and welfare listen to all of this information, they don't necessarily know where to actually look, where to focus their efforts. And so this is ultimately why we gathered this group of 140 experts in Madrid at the end of May, in order to say, from an expert perspective, across these 30 international organizations, across the civil society groups and industry and policymakers and academia, what is it that we need to do in order to scale AI effectively and efficiently in order to generate benefit for all? And so I'll talk you through preview. I will talk you through some of the major insights that we have from that session. But ultimately, it comes down to we have to foster trust, which again, we heard a lot about that this morning. We have to enable what works, and we have to find a way of preventing harm. And we have to do those three things simultaneously. We're at this unique point where we are trying to move from experimentation to scale. And how you approach things when you're in the experimentation phase and when you're in the scaling phase are fundamentally different. I saw a comic a couple of weeks ago, sadly was not in time for me to include in the presentation, but I would have. But effectively what the comic said is, once you've developed your AI solution, you are 10% of the way of getting it to implementation, because you have to worry about the integration, the scale, the safety protocols, the evaluations, and not to mention the convincing people that is actually worthwhile to adopt. There are a lot of things you have to do beyond the technology. I would dare say in many ways, and this may sound strange, but developing the AI solution is now, relatively speaking, the easy part. The hard part is integrating the solution and making sure it is available to all. So what we heard first is that we need to have a clear vision about what the future would look like. And again, we heard some of this morning, is we need to make sure that health systems themselves are going to be about people, for people, respecting people, and accountable by people and to people. All of those things are really the grounding of how to create a system that maintains and builds on the strong amount of trust that we have built with the public so far, and with providers, and with everyone. We need to make sure that the solutions are secure and digitally enabled. Obviously, we're at a point where virtually every person has a cell phone sitting in their pocket. How do we take advantage of that? And how do we not ignore the trends that are already happening? And I'll touch on that a little bit more. And then we need to make sure that we have the governance in place to make sure that we optimize our outcomes while minimizing our harms, making sure the solutions are cost effective, and recognizing that, especially with artificial intelligence, the solutions can and will continuously improve. We've already seen the massive amount of improvements that have occurred in the last 2 to 3 years with respect to AI as it came into the light with ChatGPT being released at the end of 2022. And now everyone is talking about how AI is going to shift our world. And frankly, we're at a point where it has massively shifted in the discourse. But AI, at least in some forms of AI, the more deterministic approaches, is actually an old technology. It's been around for 60 years. And yet, we need to understand, how do we actually do this? How do we create the discourse? How do we actually have the conversations with the public in order to do this? And this led to the first major finding that we have from the conference, is that scale of AI will only happen at the speed of trust. We have to understand how to engage with this tool, engage with the public, engage with our providers in a way where they will trust how AI is being used. And so within that, there are these three major aspects that we've really called out. The first is understanding where AI is going to be used. Frankly, it can be used pretty much anywhere, as I was talking about earlier on. But we can make conscious choices around where we're going to focus our efforts around how AI is going to be used. Interesting thing, I came from Stockholm 2 days ago, and one of the things that they talked about at that conference is they developed a Nordic AI map. So across all the Nordic countries, so Denmark and Sweden, Norway, Finland, and even Iceland, they now have an understanding of what AI innovations have been developed, where and by whom, and what AI solutions are in development. That allows people to say, oh, I have an idea for building, for example, a new diabetes app, AI application. Let me look at the AI map and see, has anybody already done this? Oh, somebody already has. Well, instead of me building something net new, maybe I could leverage the work that they've already done. And so in this way, people in the Nordic region, at least, are going to be able to do more with less, because they will not duplicate the type of efforts that different organizations, different academic researchers, different organizations are doing in order to advance their work efforts. So really focusing on where AI is going to be used, where you want to be deploying it at scale within Korea, but also developing the tools where it's easier for people to be able to collaborate and build on the innovations that have already been are one of the major things that, in terms of the trust that in our overall system, that we really want to foster. So we trust each other by building on the work of each other. That ties to our partnerships and engagement. How do we learn how to trust each other from a public to a provider perspective, a public to the AI developer, technology company to technology company, private sector to public sector? We need all of these organizations to work together. The opportunities from AI are too big for us to think about how do we actually do this ourselves. It must be a partnership amongst many in order to achieve our outcomes. So how do we foster those partnerships in a way that is trusted and respectful of each other? And ideally, we can elevate that trust not only from within Korea, but also from Korea to other countries, certainly near neighbors like Australia, Japan, but also some of the other countries in the OECD and around the world on a go-forward basis. The last area that we talked about as far as trust goes is we need to build the capacity to use AI. Less than 1/3 of OECD countries have actually developed a program for upskilling the practice of using AI effectively. We need to change this. We also need to think about how do we upskill the public's awareness of how to use AI effectively. We're at a point where 35% of the public report using AI before meeting their doctor for health purposes. And that number is unlikely to decrease. So how do we live in a world where the public who are using AI already are using it effectively, are using AI tools that the health system would trust being used? How do we make sure that their awareness and capability to use AI is strong? Now, at the same time, it is unreasonable to expect that everyone is going to become experts in how to use AI when the average reading level of a person is that of a 10-year-old. So we also need to work with industry to understand how to decrease and simplify the use of these AI systems so that way when the public are using them, they can use them efficiently and effectively with the aim of creating the net purpose of the health system, which is to say better health outcomes for people, better health outcomes for community, better health outcomes for the country. So all of these things, when working together, people will understand the system, they will be less worried about it, they will trust each other in the use of the system, and we're very clear about our strategy of how we're going to deploy AI. All of these things together help foster trust. But that's great. Trust is fantastic. But now we need to worry about how to actually implement the systems. And so we need to strengthen and build on our strong foundations. And with this, I will share with you an analogy. When I look at all the buildings that are built up in Seoul, none of those buildings built their own water services, their own power supply, their own waste management. They all use the same common services from the city. My question is, what are the common services that the health system will provide to innovators to enable them to be able to hook into and scale their solutions? Because the builders of all these buildings were able to build those buildings fast and effectively and safely and efficiently because they leverage the common services of the city and of the state. What are the common services that are being provided for the innovation community to be able to move from experimentation to scale? And that's where we need to think about our data and digital infrastructures, their data standards that we actually have, our technology and our cloud services that we provide the various innovators. We need to make sure that our policy structures and our processes are coherent. That is the foundation. Having said that, we need to make sure that we understand how the AI lifecycle will work as it moves from the initial concept, moves from design, development, evaluation, deployment, to post-market evaluation, and ultimately evolution of the tools. What are the different stages of that AI lifecycle, and how do we gate ourselves? How do we approve and review at each step along the way? Who is accountable for those reviews at each step along the way? Defining that will help accelerate your overall action, because if there is uncertainty about who can say yes, then you can end up in infinite loops of always looking at each other to actually get approval going forward. Understanding the life cycle and who has the authority to say yes and on what basis they say yes is absolutely essential. And that ties to our leadership and oversight functions, the overall governance of the system, to make sure that it is clear who is accountable for doing what, at what stage along the way, and what are the incentives that are in place for the innovation community to leverage the foundations that have been built, the policies and processes and data and digital infrastructures. Having said that, the last section on this area, we also need to recognize that AI is today's emerging technology. There are new emerging technologies that are going to be coming up in the next 3-5 years. We've already heard about the possibilities of quantum computing, genomics, genetics, and Lord knows what other things are going to be created on a go-forward basis. So we need to use this AI moment to understand how to integrate these new and novel emerging technologies that are moving faster than we have ever moved before, and how do we integrate how do we anticipate to be able to integrate the other new novel emerging technologies when they become more mature. We need to think about, while we're at a point now where things have never moved faster than they ever have before, they will never move this slow again. And once we realize that, then we have hopefully a sense of urgency for we not only need to accelerate, but we need to really understand how to accelerate on a systemic basis to not catch up to the speed of today, but to catch up to the speed that we know is going to be necessary 2, 3, 4 years from now. And the third and last area that we're really focused on is around the economics and financial basis. Not just saying this as a member of the OECD, But much of the investments that we've been making around artificial intelligence have been made off of trust and fairy dust. We have put money in because we believe it will change the world. Many of the economic evaluations that we have made of AI innovations have shown that they have not made the types of return on investment that we would expect. There is a productivity paradox in health where health, while other industries have increased their productivity through new and novel technologies by 30, 40% in the last decade or more, health has improved by maybe 5%, single digits in many cases. And that is because health is more complex. We are very worried about when we do integrate new and novel technologies, we need to care about safety while we're caring about the potential. But we do need to think about how do we measure the right things in order to focus our innovation efforts on things that actually will improve the overall economic and financial outcomes of our organizations. Many of you will have heard about AI scribes that are happening within many doctors. And while they can say, we can, by implementing AI scribes, we will save time from a nurse on average 1 hour per day. The reality is, can you monetize that 1 hour per nurse per day in terms of actual economic return? No, many people have not. In many cases, the nurse goes home earlier. They actually have a better work-life balance. They're able to ask deeper questions in the visit with the patient and actually end up ordering more tests, which ultimately may generate better health outcomes in the long run. But the short-term impacts of AI in that case actually are increasing cost. And so we really need to think about when we're talking about AI, because it does have huge potential, but we need to be realistic about what are the time frames under which we will get the types of returns that we want, and how do we put the financial levers in place in order to get those types of economic returns we want in the short, medium, and long term. And how do we measure the right things such that we can then understand that we are receiving and achieving the right economic returns on the investments that we're making into the system. So all of that said, the lesson is that in order to scale fast while we do no harm, we need to move from this environment where we don't necessarily have a clear target outcome for what we want to achieve from our health systems. We don't necessarily have trust amongst the public sector, private sector, with the public. We don't have a clear accountability for who is accountable for making sure that AI solutions scale effectively. And we don't have a financial justification for why. Obviously, we need to agree on what we're optimizing for. We need to engage with the public in a meaningful way and with industry in order to build and have the capacity to effectively scale and use AI. We need to have champions who are in place that have the authority to both define our foundations, leverage those foundations, and have the approval process in place to make sure that we are going fast enough while we are making sure that our solutions that we deploy are safe enough for them to be used by the public. And then ultimately, we need to be sure that we're measuring our usage, our impact, and the economic basis under which we are using the defining and justifying our investments we're making into this. We're investing, I'll say, billions of euros, trillions of won, into this overall system. How do we make sure we are returning value to the state, to the providers, and ultimately to the public to achieve the outcomes that we want in the long run? And by working together is the only way that we can achieve all of this. I do believe, with what I have seen of Korea in the last 3 years that I've been with the OECD, you are in a relatively unique position of having the strong data and digital infrastructure that allow you to be able to leverage those assets effectively. You have a large part of the trust with the public. You've built the practices in place in order to foster those relationships. It's really about pulling everything together in a coherent package that allows you to define your future and accelerate your path to the future. And when you do that, I'm going to look forward to coming back to Korea at any time in the future. So with that, thank you very much. Hope that was interesting for everyone.
Thank you so much for your impressive speech. His presentation clearly highlighted the need for AI in healthcare and the important precautions to keep in mind. 네, 보건 의료 분야 AI 확산의 필요성도.
So that was a very well-organized look at the necessity of medical AI and the caution we need to take. Let's move on to the second keynote speech, which will be given by Professor Kim Jun-ha of Gwangju Institute of Science and Technology. And the talk is titled Living Wisely with Healthcare AI from Smart Tools to Trusted Healthcare Innovation.
네, 반갑습니다.
Yes, very pleased to meet you. I am Professor Kim Jun-ha from Graduate School of AI Policy and Strategy, or GIST. So we have a lot of participants here from the medical and healthcare sector. But let me pose a question. So I am 50% dependent on AI. My dependence on AI is over 50%. If you think that it's you, please raise your hand. Okay, next question is, so I am paying a digital rent, which is subscription to AI or subscription that is more than 100,000 won. Please raise your hand if you do. Okay, so the key of my presentation lies here. So AI literacy of healthcare professionals, or HCPs, are one aspect of my talk. In the previous keynote, Eric talked about scaling fast while doing no harm. How can we scale AI with right set of policy and institutional framework? So I'm going to skip the theoretical or background information about AI. Of course, I can cover them, but I will just skip them because Eric did a wonderful job talking about that. But I'm going to focus more on how we get to where we are.
How the clinician actually lives with AI. That's going to be my talk today. 에릭이 한 이야기의 대부분은 어떻게 하면
So Eric talked about how AI can be scaled in healthcare community. So what I'm focused on today is where AI is now. So I'm going to touch upon that, and I hope to send a kind of a shockwave to everyone here. So some of you might have listened to my presentation. So basically, the content of my presentation is to show where AI is to startle you to feel that you're a little bit lagging behind. So a month ago, AI was talked about in the discourse that AI can be done. Now, after 12 months, now the theme is AI is already doing things. AI is already reached a certain level. So in the past, everything was at the benchmark stage. So ChatGPT or other LLM published different papers saying that this model is 2 times more performant than CNN, or it can write things for you. Take an example of ambient scribe. So it was more about assistive role AI plays. But now AI is already taking the lead. I don't know if you have used different foundation models. So MedPub and other validated AI related specific models are overtaken by ChatGPT or Gemini or all other general purpose models. Depending on how you use AI, your evaluation of AI can be completely different, and your diagnosis and treatment choices can be different. And ambient scribe is basically proving how AI can be utilized. So ambient scribe is the highest level of autonomy. But ambient scribe in medical is basically focusing on taking notes of conversation in the initial consultation between the doctor and the patient, and not just SOAP, but also in the next phases, AI is performing active roles. So there are 5 different phases in the AI roadmaps, particularly in the medical field. The initial stage was the level of chatbots, so generating automated responses to patient inquiries. But it moved to the research phase or reasoners phase, presenting presenting answers to the doctorate level questions, and providing readings and differential diagnosis based on CXRs and images. And we are now seeing new developments. Have you ever heard of AI agents from Tsinghua University? If you do, please raise your hand. No, not a lot. I don't think a lot of people have heard of it. But I'm going to talk about the use case of Tsinghua Hospital and where ambient scribe is now. And I'm going to also talk about what's in it for us beyond now, multi-agent workflow and other use cases. And in the later part of my presentation, I'm going to also talk about autonomous hospital, which seems to be very far-fetched right now. So first example is Tsinghua Agent Hospital. So let me first talk about the background about why this virtual hospital was created. Be it HIRA or teaching hospital or general hospitals, it is really difficult to use medical information because of the privacy protection concerns and other issues. And different organizations, including HIRA, is very conservative about taking risky decisions, and that's applied to Tsinghua Hospital as well. So using unidentifiable or anonymized data, they create a virtual patient or AI patient, and then they create AI doctor, and AI doctors work with AI nurses, and they create this virtual healthcare system and nurture AI physicians, AI doctors. They train them and they nurture AI doctor. So that was the intention. And Tsinghua University published this and announced this to the world in the second half of last year. So they claimed they're going to present different research outcomes and examples of use cases. So right now, they're at the level of training of 100 days and condensed that to 1 day. And they're in the process of training this AI to do the work that worth 10 years in 1 month. And the process is now being published. An AI doctor is trained with AI patients where they can diagnose the patient and conduct different procedures and looking at the outcome if there was any issues. Through using the feedback loop, the AI doctors are upscaled, and trained outcome is used as a training data set, again accompanied with medical literature and medical journals. And of course, human beings need to see a patient or do other work, but these AI doctors will 24/7 learn and improve themselves. And within the lifetime of these AI doctors, they can do 1,000 times more than a human doctor. Another company here is a bridge. It is SOAP related, and the satisfaction level is more than 90%. So I have no relation with this organization, but if you go there and test it out, a lot of HCPs are enticed to subscribe to that system because it is quite good. So all of these was basically engendered from foundation model, ChatGPT, Gemini, Claude, which has become increasingly popular recently. All of these general purpose AI used to be a benchmarks, but now it is moving into a clinical practice. MedPub and MedFarm were used as a validated AI model or medical AI, but these general purpose models are outperforming them. $20 subscription ChatGPT is sometimes better than PubMed and MedFarm. So what this indicates is that now the system of approving and granting reimbursement and providing fee on a particular product or item should be changed. So even when you use a general purpose AI, when it is tested and evaluated, if the evaluation or assessment is done in the right way, and if it's better and superior than a human being, it can be also approved and permitted. So the approval nowadays is on the basis of product, but it has to be on the basis of performance or outcome. AI is changing every 3 months, basically. It's faster than 3 months. Now the approval process is an annual cycle, but so it is like behind as well. So why is AI shaking up healthcare community? The first wave of foundation models like ChatGPT or Gemini are overtaking medical AI that is highly specialized. That is the first wave. And second example I'm going to present is something that everyone that learned from my lecture, listened to my lecture would know. Nowadays, this type of unified model does not exist, but it can be created with the methodology I propose. Imaging, genomics, EMR, and wearables, all of these can be converged and incorporated into a single platform. The first modality might be CT, X-ray, or imaging data. And second is genomics. There is vast amount of data from genomics, and the platform is ready to incorporate these data. And in Korea, EMR and EHR advancement level is world class, top level, but not a lot of people are thinking about how to use the data. And fourth, we have a lot of monitoring devices and wearables. In the form of physical AI, these are being harnessed. So easily put, physical AI is different from a AI you used to see on screen. So AIs give you responses to your question, but physical AI, where it goes is into the world of physics, in the real world. It leaves the screen you see, goes into a robot vacuum cleaner, to a car, or to different machines. So it's not just a virtual being that has conversation with you, but it is driving in the car, or it can take actions with the form of machine. So medical devices will now incorporate AI capabilities. If this is the case, we can create a unified patient model. So that is the second reason why AI is impacting medical community, the big magnitude. And the third aspect, dimension, is human being. So human face physical limitation, basically, and there is laws and regulation limiting working hours. And a lot of HCPs face the issue of burnout, and AI can bring solutions to these. And among OECD countries, 6 to 7 countries have very well-knit and well-defined AI strategies. Not Korea, including Korea, but around 11% of OECD countries, which is 4 or 5 countries, have systematic AI training program focusing on AI literacy. And it saves about 16 minutes out of 8 working hours a day for administrative and documentation workloads. So this is a very valuable time you can save. And in Korea, I think the hours saved or minutes saved might be larger. So right now, we are still in the initial phase and it's 16 minutes. If you feel any change, it might be documentation automation when you are putting together SOAP or other administrative documents. And next data point is 74% reduction in ACP burnout probability. So 16 minutes saved can lessen a lot of work burdens. And in Korea, a higher percentage documentation automation is already reached certain level. And you said you are paying more than 100,000 won for a subscription, so you have less chance of facing burnout. So using ambient scribe, ACPs can also lower the cognitive load during the consultation. So even when patient is saying things, when you're under a lot of cognitive load, half of what's being said cannot be really captured in your brain. 68% says there is 78% reduction in ambient in cognitive load with ambient scribe. So ambient scribe adoption rate is 68%. So basically, all of these foundation model, unified model, will lower and work to minimize the load in and outside of consultation room. So the example that I talked about, the virtual hospital, the simulator patient, doctors, nurses, and devices are all virtual there, but we have abundance of data. So Tsinghua University Virtual Hospital nowadays have 42 AI doctors with 32 departments and specialties. And now the simulations are numbered at more than 10,000. So it means more than 10,000 patients were simulated. And MedQ, the accuracy for QA qualification, medical qualification test is 93%. So in virtual simulation, the accuracy was above 93%. So up until now, AI was all about answering your questions. LLM stayed inside the screen, and now it is out of the virtual world into the physical world. So AI is now directly administrating workflows. So this is one of the reasons why new changes are visible. China has advanced significantly. What matters is not if United States is number one, China is number one. And China is trying different innovative attempts. One example is virtual hospital. And virtual hospital is basically a digital twin. So administrating a medicine or testing a new innovative treatment on a real patient is very difficult, but through simulation, using the data, anonymized data about the patient in these virtual hospitals can benefit the patient and lead to better outcome. And in 2024, AI received a Nobel Prize. It was a huge milestone. AlphaFold 3 was basically a laureate, and in 2020, AlphaFold 2 was announced. It was all about prediction. So this might be possible. This can be predicted. But in 3-4 years, not only predicted the interaction between ligands and proteins, it can now create the actual new proteins. It can engineer new drugs, and it already has done it. But the simulator basically received the Nobel Prize and gained momentum. And this new drug that is designed with the help of AlphaFold 3 is now clinically tested in a clinical study. So AI, in your mind, might be all about automated documentation, but this talk of mine today can help change your perception. Now AI is ushering in the era of personalized and precision medicine.
The top
And Korea is a leader when it comes to EMR, but what's the problem is that the deployment is pretty slow. So we first have to deploy AI and do the monitor. And there are very few countries that can do post-deployment monitoring, and Korea is one of them. We have the penchant to get things done quickly, and also another advantage that we have is that we pursue everything in parallel. I don't know much about the medical field, but I think that most of the HCPs in Korea, they do have some situations where they can pursue development in parallel. So compared to other countries, the Korean regulation is not lagging behind. And if there are any laggage or any shortcomings, then yes, we can make up for that. And if healthcare industries about 5 years ago, actually they were not really well developed. But then thanks to the Korean government support policies, various healthcare projects were initiated and industry started to develop and design new products. But the problem is still with the deployment. So the AI has not been deployed in hospitals yet. But if they are deployed, if they are adopted in hospitals, then I think that not just the conveniences that I described so far, it also ensures the accurate diagnosis and safe diagnosis. So post-deployment monitoring is something that we have to consider because human beings, they are excellent in monitoring what others are doing, although they are poor at the things that they do by themselves. So we can let AI do the job and then monitor what AI does. Especially recently, I actually authored the 4 books regarding coding. And so I actually removed the codes from all my books. And then I came up with a new book called Zero Code Data. And while I was rewriting this book, what I realized was that 30% of my book was about the hallucination. So it was about, in other words, I have to admit that I had my own hallucination. So this is something that I learned while working on AI. So I removed my hallucination 30%. So my new book became more accurate. But then the more you're experts, the more hallucination or the deeper hallucination you have. So you really have to take a deep, sometimes you dive too deep and you cannot be rescued from your own hallucination. So in the sense, in this regard, you can utilize the AI for monitoring yourself and making improvement and making correction. So let me give you an example. So one patient for a minute, which means that it takes 4 minutes to see one patient. So this is a scenario that I can present. even right now. But today I will be just talking about a virtual scenario. Let's say that we have a 67-year-old man who presents the 3-week history of dry cough, and he just had the chest x-ray and he's waiting to see the doctor. So whether it's the dipnoid or the lunate, so we have the great technology for CXR medical imaging and interpretation, and only in 10 seconds, this diagnosis result came out. So here you can see the diagnosis. And on the right-hand side, you can see the actual image. And on the left-hand side, you can see the chest image from dipnoid. And AI makes a comparison between the two, and it takes 10 seconds. And then after that, the SOAP is created. And then it is converted into STT. And then the SOAP is summarized by AI. And then with the notebook AI and GenSpark, we can actually create the video that's customized for the patient. So the notebook LM, for the lack of information, they can recruit references to make up for that. And then the GenSpark could make decisions. So notebook LM and GenSpark, I believe some of you use this, and if you hear this for the first time, please try to use them. So it can create a podcast for the patient to view the materials on a mobile device and listen to the podcast. So if you send the QR code to the caregivers, then they can also have access to this podcast video. So 4 minutes is enough for the consultation for one patient. And the final decision should be made by physicians, the doctors. So here you can see that 3 AIs are working in a unified manner for one patient. And if that AI is available, then the doctor can see that they could enjoy a huge cost savings. So 60 minutes less for the documentation. And also the AI can provide a 3-minute well-elaborated explanation to patients. So AI will not replace doctors, but they can free up the doctor's time. So the final decision will anyway be made by doctors. So today we talked about the trusted AI, and so this is where the everything that I previously described fits in. And I think that with the current technology, we can actually address 90% of them. So when it comes to performance, transparency, and governance, in fact, the technology today is much more advanced than what you expect. And the physicians, so what we need is creativity and perspectives from physicians. So if the medical experts give the idea, then non-medical experts like me can develop technology. So for this, the physicians and medical experts, they have to use AI, and they could identify what areas to be improved, what areas to be developed. So we have a lot to cover, but because time constraint, let me just say this. So this is what Korean healthcare AI should stand in 2028. So there are 5 priorities. And what's most important, I think, here is the AI literacy for healthcare professionals. So 11% of OECD countries to have AI training program, and also Korea is not really an exception in this trend. And therefore, we have to start developing HCP's AI literacy. Then I think for the Eric's question, that can we scale fast without harm? And my answer is by finding a wise way for doctors and patients to live with AI, we can scale AI fast without harm. So with that, thank you very much.
네, 교수님 좋은 말
Yes, Professor, thank you very much for the very interesting presentation. He mentioned he hoped to shock everyone with his talk. Are you? I myself got very surprised. So the final message, AI and doctors need to go hand in hand. It's something we all need to remember. So we are now done with 2 keynote speeches. Once again, I would like to thank the 2 keynote speakers. The morning session of today's symposium come to an end. In the afternoon, as was mentioned, we will have 4 different presentations and a panel discussion. And YouTube live streams begins at 1 o'clock. So please come back for the
So did you enjoy your lunch? I really enjoyed. Now we would like to begin the afternoon program of HIRA International Symposium 2026. For the afternoon session, we have total 4 presentations in store for us, which will be followed by a panel discussion session. So let me introduce the first speaker. From Melbourne University, we have Honorary Professor Stephen Duckett, and he will be talking about institutional integration of medical AI, policy, and oversight challenges. Please give him a big hand.
So my name is Stephen Duckett. I'd like you to cast your mind back 6 years. Unfortunately, it's to the COVID period. In Australia, we woke up every morning with new information about COVID that had been published in the United States or in Europe. The information, the knowledge of how COVID was transmitted, how COVID could be treated, how COVID could be prevented with vaccines was changing extraordinarily rapidly. Every day we knew new things. We knew old things were wrong. That is the world we live in with AI today. Unfortunately, everything I tell you in this talk is going to be wrong by the time I finish this talk. So you can go to sleep because things are changing so rapidly. I'm going to talk about 3 things. What are the risks that need governing in AI governance, rethinking the concepts, and oversight. By governance, I mean making sure that the technology we build, use, deploy is doing the things we want it to do and not the things we don't want it to do. What we do know is the cost of using AI models per use is going down. What we also know that use is going up. We're all getting addicted to using AI. And one of the issues for organisations is once we get addicted, how much is it going to cost in the future, because the pricing models of AI are changing rapidly. The good news is AI is getting better and better every day. The bad news is there is still a gap, and that is the gap that governance is all about. It is that gap, the risk between what we want in terms of accuracy and what AI provides in terms of accuracy is what is the challenge. There's a lot of talk about AI. You see in this graph what's being done, which is the top line, and what is being talked about, which is the bottom line, the dark blue versus the light blue. Lots and lots of discussion, not so much implementation, also not so much evidence. There are only 19 randomised control trials when I did these slides, which talk about what actually are the actual benefits of AI. So what we need to think about is this gap that I showed you. We need to have the issue of, does the new technology, including generative AI, improve outcomes and reduce costs, which is what we're trying to do. And there is a checklist that you might go through in all of this. You might think about, does it identify a nationally recognised priority? Does it improve patient interactions with their healthcare providers? Does it reduce the number of steps in a clinical pathway? Does it actually save money? And I think there was Eric who said, can we actually monetize the actual savings with an AI scribe? There are other things. Does it provide real-world evidence? It's all very well to talk about it. It's all very well to have an AI description which compares a text with what an AI would say. But what happens when we actually introduce it in the real world? Now, the issue for governance, for a board, for an organisation, is before you implement it, you don't have that real-world evidence in your organisation. So what strategy do you have to make sure you evaluate properly, both prospectively and retrospectively? And finally, we've got to think about payers and providers and patients may all have different views about this. Now, the risks of AI have been known for a very long time. This is a famous article published 5 years ago, which is generations in AI terms. It's got a beautiful title, and in fact, it's one of the few articles which has a parrot, an actual parrot, in the title. You can see it on the right-hand side there. But basically what it says is when this group were writing back then, AI is literally just prediction of tokens, prediction of what might work together without any reference to meaning. Even though when you type something into AI, it talks back to you as if you're a human. I did this, it will say. But you've got to remember that it is reporting back to you what it has been trained on and what it has learned from what it has been trained on. And because it is learning, because generative AI is no longer an algorithm which says if this, then that, performance varies in unexpected ways because people write their prompts slightly differently. And because performance varies in unexpected ways, it is very, very hard to regulate, which means that the regulation of AI is not keeping pace with the use of AI, which has hazards for all of us. And this is from a European regulator, a consistent finding across the evidence is that existing regulatory approaches are not well matched to the systems because of this variation, because we cannot say for certain this follows that. You might say, let us benchmark what we do with AI today versus what we do with AI tomorrow. A recent last year review of about 110 studies found that quantitative benchmarking of AI is currently ill-suited to primarily provide the safety and capability assurances that policymakers need. So the governance context is highly complex. We know the risks. We've known them for a long time. People are addressing them. The privacy and security risks of AI are very similar to the cybersecurity risks that every organisation now is dealing with. The risks of misinformation are not the same that we've dealt with before. The risk of malicious actors is the same we've dealt with before. And so there are very similar risks, but there are extra risks that we need to think about. We also need to think about AI risks compared to humans. It's all very well to say AI is trained on a different data set and you get the bias from the training sets that AI used, but humans have bias as well. So there is bias and risks of bias in AI, there are risks of bias in humans. This slide, which you probably can't read, looks at the way AI has been trained and how it fits. And the pink egg on the right-hand side, on the left-hand side of the slide, essentially are Western wealthy countries, and the fit of AI, GPT in this particular case, is pretty close to those Western countries. South Korea, the fit of GPT is not as close to what the South Korean culture is and so on. So you have particular additional risks. The risks of AI include, and I just want to draw attention to one of them, issues about intent. That is, with AI, we have to always think about the intentional and unintentional, and the intentional risks may be malicious. And so we've got to think about, has that happened? Also, I don't want to harp too much on risk, because we've got to think about the risks of AI use and the risks of non-use of AI. AI can do good things. As I was talking about this at lunch today, if we are looking at radiology, for example, is it ethical today for a radiologist not to use AI? What are the risks? What do they miss out on if they don't use AI? I'll skip this. But basically what we're showing here is the risks that people talk about are ones which are well understood, but we have to be prepared for them. And in particular, I'd like to mention this nicely phrased comment here about what is called the recursive, what is now called the recursive care law, that the data, AI is trained on a particular data set, and it exacerbates, amplifies what is in that data set. So unequal care produces unequal data, which produces unequal model development and produces further unequal care. So being really careful about how we are using AI and where it is being used for. Now, very often you hear that the answer is human in the loop. And of course, that was true with the introduction of the motor car. We had a person walking in front of the motor car with a red flag originally. That didn't last very long. But as I said, human in the loop might have the same confirmation bias, ordering effects, and so when they come to read an AI script or whatever, they might have their decisions framed already by what's in the script, and so a human in the loop, so-called, doesn't do everything you want. That is, when corrections were required, for example, in these studies, annotators were less likely to revise pre-annotations, suggested that they got bored with doing the corrections. And depending on your skepticism, you might do more or less corrections. So humans, putting a human in the loop doesn't fix everything, as I'll come back to. So then people are talking about new policies that are required. But in fact, there are very few new policies at the national level, which are what this study suggests were high impact. Lots of policies about transparency and governance, safety and risk, but most of them are middle of the road, not very clever policies, according to this. This is another look at where AI might be and what the risks are. And they talk about some things being low risk, some people's being high risk, but basically the model suggests the more narrow the scope, the less risk. The more autonomous, the greater the risk. And so if you're narrow scope, low autonomy, many administrative applications are of that kind, low risk. If you're high autonomy, broad scope like generative AI on a big data set, more risk. Now this thing is about clinical applications. Administrative applications generally have lower risk. So what are the risks that need governing? The risks are known, they've been known for a while. There's a lot of naive optimism, but things are changing rapidly, and this is particularly important for evaluation. We need to be aware that the old models of evaluating, regulating static systems, algorithmic systems and so on are failing, and we need to actually think about what is happening within organisations, and I'll come back to that later. So, governance is about risk and managing risk. If you've been involved in risk governance in any organisation, you'll see a typical risk matrix, which has probability or likelihood of risk on one dimension, the impact on another, and you get assignment to red, green, amber scores in a risk matrix. This is from a think tank, and it talks about high impact, low risk, and so on. But I would argue that that standard risk matrix approach no longer works when we're talking about risk governance of AI. As I said, every organisation has a risk matrix: likelihood, outcome, probability, assign it to a square. Why doesn't it work? Why doesn't it make sense to think about high impact, low risk? Oh, pretty obvious. It's wrong. Because assigning a single probability and a single outcome is not possible anymore, because we don't know the pathways. Started this talk talking about rapid change. Things are changing so rapidly that an assessment a year ago is not an assessment today. There is so much uncertainty. There is so much likelihood of things that we can't even imagine. And on top of all of that, we haven't talked about the culture, how an organisation actually responds. So the risk approach of the old days is not going to work in the new days. And this author is talking about organisational change, but many of the same things apply in terms of thinking about risks. And what he says is that the core argument is uncomfortable. Most of what passes for change management, risk management, is security theatre. It makes executives feel they're in control, and they're not. And then he goes on to say that what is happening in organisations with change is happening right throughout the organisation, and you cannot control it. The same is true with the use of AI, and I'll come back to that. I'll come to it now. This is a report done by the Auditor General for Ontario, one of the largest Canadian provinces. The Ontario public servants were assessed in terms of their use of AI. Of the 400 AI websites that staff accessed over a 6-month period, 60% were deemed unsafe. More interestingly, the public service approved the use of Microsoft Copilot, basically, and that was the approved AI in the Ontario Public Service. That accounted for only 6% of use throughout the Ontario Public Service. 94% of use of AI in the Ontario Public Service was not approved. It also found that there was an assessment of AI scribes, for example. 12 of 20, and there were a series of vendors approved for AI scribes in Ontario Health Services. 12 of the 20 provided incorrect information. 6 provided incomplete information. 9 of them hallucinated. This one is about use within a number of organisations, and they had approved the use of the organisations had ChatGPT, so they could measure who was using ChatGPT in the organisation. And if you see there, early career people were using ChatGPT a lot. There are 2 different measures. One is standardised for the firm, but early career and trainees were using it a lot. Executives, second from the bottom, not so much. IT professionals, somewhat. So you can measure who is using ChatGPT, for example, and it is totally uneven across an organisation. So what's the implications for governance? Beware of centralised thinking. Beware that if you have a policy about AI, everybody is following that policy. They are not. The best protection is to get teams together, to work together, to have an open and honest conversation about using AI, working about what is happening, why they're using it, and what they're doing with it. Because the person at the front line will be the first to identify anomalies in centralised rollouts, their voice has to be heard in evaluation. And of course, as I said, you've got to rethink the standard risk matrix. So I now want to talk about different levels of governance. The national level is critical. And again, oversight at the national level is not keeping pace with the rate of change. In Australia, for example, the regulator, medical device regulator, has said, we want to think about regulating AI scribes. If the AI scribe is just reporting back what it heard during the consultation, that does not need regulation. But as soon as the AI scribe says, have you thought about X? Or I think the diagnosis is Y, it starts to need regulation. And even though AI scribes have been in place for a few years now, that regulation is not in place. We also need to think about the complexity of regulation. I'm on the board of the telephone advice service for Australia on health. We have essentially an algorithmic approach, not quite true, but an algorithmic approach. So we can say, if a person says X, we can see and trace the logic to the recommendation. With generative AI, you can't. So what is it? How do you deal with that complexity with the development of agentic AI? And of course, in many cases, these are proprietary products, and so we have no idea what is inside that black box. So there is now a whole lot of work being done internationally about how you deal with this. The European Union in particular is doing a lot on that, and talking about national sovereignty of data holdings and so on. But if AI is also an existential risk that is bigger than individual nations or even groups of nations, how do we deal with national sovereignty? What's the trade-off in terms of trying to deal with things internationally? I've mentioned human in the loop. That has multiple meanings. They're very, very different. And sometimes basically talking about a human in the loop functions more as a ritual of assurance rather than a substantive. That is, it makes you feel good. It makes you feel like you're on control, but you're not. And as I said, as this slide shows, there are multiple different meanings of human in the loop. And just to give you one example, you might have AI handling lots of things on the left-hand side, and referring things up to a human expert to make a decision, versus AI is providing advice to lots and lots of workers. Very, very different impacts on the workforce, very, very different meaning of human in the loop. Next, going on to the organisational level, same sort of issues as apply at the national level, rapid pace of change, framework still developing. They all have to be within the context of the national level, so there's a lot that is undone and unknown. This is a set of principles that Microsoft has said for its organisation, and it has, as part of its own organisational control of AI, has identified these 6 principles, including down the bottom, everything has to be clearly accountable. But some of these are well known, like, for example, privacy and security. We've been doing that. Cybersecurity has been at the forefront for a very long time and still is important in the AI context. But so too is every one of those other things. Fairness, for example. I've talked about bias and transparency. How do the decisions made? So that's an example of an organisational framework which has a whole set of principles. Finally, we come down to the individual level. Again, individuals right throughout organisations are making decisions right now and very, very quickly, adopting AI or not. And the issue then becomes, we've got a formal policy over here, and what makes sense to a worker over here? What happens when they come in conflict, and how do we actually regulate and so on? So, where do we go? In the case of trying to regulate this disseminated use of AI, what I've talked about there is, rather than saying we're going to manage risks, we just need to understand them. We need to make sure that people are prepared to talk about those risks, to actually raise the risks. If they see something that seems odd in the way AI has provided advice, they are prepared to talk about it. So we've got an evaluation mechanism that works in real time and management can hear it. That means the people need to be free to talk up. They need to be free to understand that they are critical. They are, inverted commas, the human in the loop, and the culture needs to be one where people can talk about the problems. People need to be trained. People need to have the delegation, and the organisation needs to know where is AI already being used, including where it's being used without authorisation. So, what do you need to do? You need to have a vision for AI use. You need to be talking about why we are using it, not what we're going to do, but why are we doing it? What's our aim? Is our aim to reduce cost? Is our aim to improve care? And so on. And what are the costs of use versus non-use? Because we keep forgetting AI costs us something, but not AI also costs us something. We need to understand the risks. I've talked about that, including environmental risks. What are the risks to the environment of this huge electricity support for the data centres and so on? And as I said right at the beginning, what is governance? It's about making sure that what we do is what we intend to do. Our oversight strategy needs to have clear accountability, clear monitoring systems, clear post-implementation review, and we need to have a change management strategy to get from here to there, which includes upskilling both the board, the leadership, and the people who are going to be using it. And we already have mechanisms. There's international standards relates to data security, for example. So you can incorporate AI into already business as usual, which makes it easier for organisations to adapt. Implementation needs to be consistent with sort of standard approaches to change. It needs to be transparent. You need to involve the staff. You need to make sure that your algorithms are audited and so on. You need to have clear, explicit accountability, including who is responsible for the model outcomes. It's all very well to say, oh, AI told us this, but there needs to be clarity that the machine can't be accountable, someone has to be accountable. We need to have clear values in the design, including trade-offs, efficiency versus fairness, accuracy versus autonomy. And we need to communicate to get the change implemented. So here's my final list of what we need to do, why we need to do it, and so on. The first thing is AI technology is not a topic that is on your agenda. It should be the way you see things. So in another organisation I chair, we require management to tell us, how does technology enable, threaten, change this proposal? So technology is a lens through which you evaluate things, not just a topic or a checklist. It is quite a different way of thinking about it. And if you think about technology as a lens, not as a topic, you get to think about AI technology all the time and thinking about how it is all pervasive. When you come to AI, you need, as I said earlier, you need to think about the why. What is it that you're doing? Why are you doing it? We are not just following the herd. We have specific objectives that we're trying to achieve. And as part of thinking about those specific objectives that we're trying to achieve, you need to understand the risks. The risks of AI are quite different from risks you have previously encountered. They are risks of equity, risks of bias, the risk that the data has been trained on a particular data set and therefore it provides advice about that data set. Remember what I said about the recursive care law. There are risks to the environment that every organisation now has to be thinking about its environmental, social and governance accountability, the so-called ESG rules. What is the contribution of AI to our environmental issues on this planet. AI can be used at any stage of the clinical process, including the back office, the administrative and so on, much less risks than some of the other areas. But so too, AI can be used in the clinical setting as either diagnostic or treatment. Use in diagnosis is much less risky because you have automatically a clinician is part of that. Automation of treatment is much more risky, but it is already occurring. In the US state of Utah, for example, the government of Utah has approved a company to provide script renewal automatically. The human talks to the AI, and the AI writes the prescription for the medication. No human in that loop. It is happening already. AI governance requires you to think about, do you have the skills to deal with all the issues that I've talked about today, the rapid change, the risks that are somewhat different from the risks we've had before, the implementation across an organisation. Is AI in your organisation seen as being about data and the data people, but what about everybody else? How are we improving? What is our upskilling plan for everybody in the organisation to know a bit more about AI, including those right at the top? Remember I said they use AI very little, but they need to know what AI is, what the risks are, and what are the choices, and how have they made those choices. Change is happening everywhere in organisations, increasingly so. Who is responsible for that change? As I showed you, there are people right down the organisational change, the early career people, who are using AI. What are the guardrails associated with those people right down the organisation who are using AI? AI is happening everywhere. Remember I said about in Ontario, 6% were using what they were supposed to use, 94% were the use was not what was supposed to be happening. We need to be revisiting clarity of accountability for each use, and just saying you can't do it is not going to work, because they might be using AI at home to help them with their work. Right now, token prices are relatively low. The business model of all of these AI companies is going to change. Token prices are going to go up. Are we ready for that? What have we achieved the benefit? Do we know how we're going to deal with the change in the prices? Cybersecurity risks have been with us always. They're increasing. And almost finally, what I want to talk about is post-implementation. Let's say you've got an organisation-wide AI strategy. What is the mechanism to get feedback? How are you going to learn from the people at the front line? How are you going to have a culture which means the people at the front line are going to tell you when things are going wrong and when they're not going wrong? And what is the mechanism that you are establishing for ongoing accountability and ongoing oversight? And as the very last point, I've talked, I won't say gloom and doom, but I've talked a lot about governance and risks of AI. Remember, though, that AI has a lot of benefits. And so, as with any management decision, what we're talking about is a balance between the risks of using AI and the risks of not using AI. And we often forget that there are risks of not using AI. Patients might miss out because an AI processing of the patient data may give better, more accurate information to help diagnosis and treatment than that very same patient without being supported by AI. So, as I said, finally, the issue is we need to weigh the risks of use of AI versus non-use. And that is very, very hard, because talking about what you're not doing is much harder than talking about what you're doing and what you're going to do. Thank you very much.
Thank you so much for sharing your insights with us. 의료 AI의 제도
He shared valuable insight about institutionalizing medical AI. We will now move on to the second presentation, which will be given by Professor Leung-Park of Aju University under the topic of AI-driven healthcare innovation. Please welcome him with a big round of applause.
네,
Yes, good afternoon, ladies and gentlemen, distinguished guests from home and abroad, and those of you who are joining us online. I'm very pleased to meet you here. So can we change the presentation slides into the Korean one that I've shared with you? So I'm a surgical pathologist. I gained the board approval in 2007, and since then I only covered medical information related specialty for more than 20 years. So are you working on switching to the Korean version of the presentation deck? So I will just proceed and use the Korean deck when it's ready. So AI-driven innovation is happening really fast, not only in the medical field, but everywhere else as well. AI has created massive change so far, but it will create even more going forward. And there have been a lot of innovations in the medical field and domain, and though the changes we are in for are unprecedented. Amid the situation, of course, Korea showed a lot of developments and progresses. And in the global competition, Korea has our strength and areas for improvements. And I'm going to focus on what we should do to overcome our limitation and what HIRA can help. So please switch to the Korean presentation deck because the letters in the English one is really small. So I'm going to first talk about AI algorithm and changes there. And second subtopic is Korea's strength. And there is, of course, the Korean paradox where the abundance of data doesn't mean the utilization of data naturally. And there are 6 bottlenecks I will talk about, and regulatory barriers, and global benchmarks from Europe, the US, and Japan. And I will also talk about AI shift. In the past, AI was developed for a particular purpose, but now AI is all about multi-model and multi-purpose. So the last bit is what we need to do and what HIRA can do. So up until now, of course, for 26 years, I was involved in dealing with data, processing data, analyzing the efficacy and side effect of different active ingredients and drugs, and what patients are more prone to show adverse event, side effects. And there are competitions regarding which algorithm is the best, which medicines are best, most efficacious. But now the competency is all about pipeline where data can flow into AI and how AI algorithm can be used. So can you raise your hand if you cannot live without AI? Okay, I think President of HIRA and I agree to that statement, but everyone else can live without AI. So in the morning, until I get to this hotel, I didn't drive. Of course, the president of HIRA might have your own driver, chauffeur, but I was driven by a car. So is there any Tesla owners in the room? Surprisingly, only one person raised his hand. So I own Model S Tesla vehicle, and this is full FSD competent. So full self-driving is possible through Model S, and I've already my mileage on FSD. On my car is 18,000 kilometer, and most of it was done by FSD. My commute is generally FSD, so I cannot live without Tesla now. I doze off sometimes, but if it's seriously dangerous, I would not be standing here. I would be in ICU. And with FSD Lite available in Korea, about 10,000 vehicles can now be fully self-driving. So once you experience that, you can go back. And whenever FSD is driving my vehicle, I always get waves and smiles from pedestrian because the FSD takes care of pedestrians. So we are not living in the same world. I am living in the world where I cannot live without AI, but you are not there yet, I guess. But these changes will be upon everyone sooner or later. So I cannot really read the slide, so I'm going to just hold the microphone and step closer to the screen. So AI advancement is astounding. Transformer large language model like ChatGPT brought in new ages for us. There is a pressure for technology advancement, and in the medical field, the quality has become overall higher than before. But on the other hand, very expensive new innovative drugs are squeezing the financial resources out of the system. And the expectations are higher than ever. So all across the board, we have experienced a lot of changes, and remote consultation and new these methods have been introduced. So I served as a chairman of Korea Medical Information Society in 2017. It was before COVID, but I distributed noise canceling microphone and echo canceling speakers to 30 executives of the society, and we used WebEx then. A lot of people resisted, but in 2 years' time, COVID-19 broke out, and the society had no hardship switching to virtual operation. But in the beginning, when I started to hold on offline meeting, everyone complained, but now it's part of our everyday lives. Everyone has cameras, webcams, echo canceling hardwares, and web conference software. So different pressures were at work to push us to the next phase of changes. And Eric Topol said, the printing press democratized knowledge, and digital health democratizes medicine towards patient-centered care. So in terms of professionalism, the medical field always had a set of professionals who can make highly skilled decisions, but now AI makes that decisions more widely available and accessible. And another reason why I cannot live with AI, to share another anecdote, is a year ago I was involved in litigation. So at the time, I hired a law firm, but I canceled it in 48 hours. But the law firm refused to return any money. The money I paid when we started the litigation, it was a large sum of money, and the law firm have 13 lawyers, and I filed a suit against them. And the litigation went on for 9 months, and I got the money back. So I did not know anything about law, but they had 13 lawyers. But I had an expert, which was named ChatGPT. With the help of ChatGPT, I did online litigation. I wrote all the documents. I appeared in court 2-3 times. So there was a lot of exchange of documents in the middle. And ChatGPT also found case laws, and I won the case. So I thought, at that law firm, they had 13 lawyers with abundance of experience, but nonetheless, they lost the lawsuit against one doesn't know anything about law, and they might have felt helpless, and I feel thrilled. So these two examples, full self-driving and my victory from this lawsuit, make me feel that I cannot really live without AI. So I cited some examples, but just like tsunami, in all part of our lives, we are seeing this huge wave of AI. In 10 years' time, half of you will be relaxed and ledgering off, not because you're unemployed, because you became far more productive. So in 10 years of time, I think those who want to work will be working only. So this is a little bit of preamble. So now I see the Korean language presentation. Surprise, surprise. So as you know, Korea has world-class medical data. Just like in Taiwan, Korea has single-payer system with national insurance system, and 98% are the subscribers to this national insurance, 2% Medicaid. So all patient data is available in a single platform, let's say, and EMR adoption rate is 94%. Of course, there is controversy regarding quality of EMR, just moving paper-written record onto a computer system. Ontologically, it's just mandatory requirements, but still, EMR availability is really high. And more than 3 trillion claim data is available. And OMOP, CDM, and other standard data are all used by key centers. And now, 1,263 health information highway is being built in more than 400 systems are being built that are based on FHIRA KR core network. So it's all rosy, but the paradox is we have so much data, but not a lot of data that we can use. So from a data to an actual marketable outcome, there are 7 different steps. So from the ideation phase, we need to acquire data and cleanse the data and standardize and process the data. And based on the data, we create an algorithm that fits our hypothesis and validate that and pass a regulatory approval procedure and commercialize the idea. But the problem is in steps 2 and 3, a lot of time is wasted. The data, EMR data from general hospitals were converted to OMAP CDM, and I was working with different hospitals during the time, and the hospitals were saying the same thing. We cannot give you the data. Our data quality is excellent, but other hospitals do not have that high quality data, so we cannot be in the same one. And our IRB is really competent, but IRB from other institutions cannot be trusted. So there were a lot of issues. So the key here is data acquisition is so difficult, and units and reference ranges, all these data are so disconnected and they're not aligned. So data cleansing requirements are so high. So much of the time, 80–90% of the time across this pipeline is wasted in steps 2 and 3. So in order to overcome this, we need to be able to harness the data for further innovation. So we need to overcome 6 different bottlenecks to make data more readily available. First one is data accessibility. It takes months to years to gain access to data. And we need to extract data from different institutions. It's really difficult because standardization is not done. Of course, EDI made a little bit of correlation possible, but here I will know firsthand it is not enough. There are just so many different formats and versions, and there is also an issue of quality and the authority of approval and permission. So we need to get into the conversation with hospitals. So it is sometimes unclear who makes the final decision. So hospital president says okay, but the head of medical department says no. And sometimes clinical department will permit the data usage, but an administrative team would say no. But you need to overcome and go through these procedures one by one. And all the hospitals have different set of procedures, and you sometimes do not know why you cannot get permission, why you cannot have a certain conversation, and you persevered all through that, and you reach IRB and DRB phase. And now the law has changed, and now IRB and DRB can be merged, but the topics and domains and expertise are different. So these IRB and DRB, I believe, will have independent processes under the same roof. And DRB's role is to see if there is a privacy and data protection risk regarding data. But I am also a part of some DRBs, but decision-making process is not scientific sometimes. Some research go through DRB really easily, but for example, if the parameters, if the variables are larger with 1,000 patients, it will get rejected. And if you're only looking at 100 patients, still the data volume is high and you will get rejected. So there aren't clear criteria or standards against which the decision is made. So I hope to see a well-structured tool where the privacy issue or risks can be measured more scientifically. Maybe on a scale of 1 to 10, the risk is 8 or 7, according to this scorecard. And DRB committee members can set the threshold. We can say yes up until 8.8 out of 10. If that is 9, we should reject the project. So it will be optimal to see a certain tool that can facilitate the decision making. And it takes so much time to get evaluation, extraction, and approval. To get the data, more than 40% in Europe and the United States use EPIC. But in Korea, EMR are all in-house developed, very customized. The structure of the screens and ontology are all different, and system management. Sometimes SI companies take care of the system, but sometimes the EMR system is operated and managed by the hospitals themselves. And even when you are using certain vendors' product, oftentimes these vendors will not allow access to the system. So this vendor lock-in, because there is a lack of appropriate regulation, also creates a hindrance. But in the United States, with the 21st Century Treatment Act, denying access to information is illegal, but that's not the case in Korea. And when you see OMOC CDM, it is nationally undertaken, but there are still a lot of data that is not standardized. Unit variability, differences, discrepancies are widespread. When you look at CDW's field, when it says age, you might think only numerical value can be added and put in there. But when you look at critical data house and data fields, everything is text-based. You can put in anything because in real-world data, there are unimaginable data. For example, there is a male patient who did hysterectomy according to the data, and prescription is written to an unborn baby, and post-mortem diagnosis is a prescription is done, and someone is 99 years old with 40 centimeter height. So when you look at EMR, maybe because human error, maybe because of different reasons, there are so many preposterous data, and all this data should be cleansed and bring some order to that, but that is remain untouched, which create serious bias. And of course, there is firewall. I mean, you place an order to Coupang or Korean Amazon, and when the product is inside this fresh bag, that's fire. So the bag is standardized, but what's inside is not standardized. So the format in which you transform a content is standardized, but the content itself is not standardized at all. So sometimes identifiers are missing. Sometimes when you look at lab test, there are different time values. Do you know how many time values there are for a certain test? So there is a time where the test is ordered and when test is performed and when the test outcome was generated. Which data is most important? Which time is most important? Do you need when the test is ordered or order is performed or the outcome is reported? So the last one is important, but the sampling time might have some gap between label printed time and the sample time. So there is a little bit of congruencies. So the association between times are all complicated. And when analysis is done, why or intention of doctors for prescribing that test is really important, but that is really difficult to read. So the context or unsaid parameters in different healthcare providers or centers are very different. So KI Core project is conducted by Ministry of Health and Welfare. HI 7R4 is being implemented to standardize the package within which you get the content. So HRL7 and HKIS were co-developing this in 2023. So KRCDI, core data for core interoperability is implemented. So it is limited to 7 data sets in 14 different categories. But this is not enough. We need far more data for analysis, but this is just an initial phase. So the scope is a little bit limited. So I hope to see the KRCDI to be propagated further. So KRH 7 tab need to be inside EMR systems. So we can add more content if we can change the content when the package is standardized, and we'll be able to understand it better. Of course, the EDI codes and other things are used together, but they are not enough. So we are still in the beginning phase, and there are more criticism regarding KI core, but nonetheless, we need to start somewhere.
So 아까 말
So let's say we secure the data and we standardize the data and creating the AI algorithm, but still the approval process is never easy. But thanks to the Korean government's effort, the regulatory pathway is gradually being put in place. So Digital Medical Product Act took effect in January 2025, and also the Digital Therapeutics law was established. An AI Basic Act was adopted in January 2026, and medical AI is also systematically managed as high-impact AI. So these are something that we have done a great job, but still, who purchases, who pays, it's not clearly defined. So without the definition, no matter how great systems and institutions we have in place, still it cannot work in the market. And also the formal listing is important, so that's why the payment, the reimbursement has not been structured yet. And also again, who pays is not clearly defined yet, so that's a major issue. And also, with regards to the institutions and regulations, we have a lot of regulations, and oftentimes the jurisdictions overlaps. So we have the PIPA and also Bioethics and Safety Act, and there are duplicated areas and also gray areas, and oftentimes rely on soft laws, which lead to a lot of ambiguities. So, for example, like for DRB review, as I mentioned earlier, they rely on the guideline issued by the Ministry of Health and Welfare, and oftentimes they are not really clear. There are a lot of gray areas, so that leads to the confusion and ambiguity. And also, for example, like we try to prevent the information leakage with the PIPA law, but it's not really clear what's the threshold. If the directors of the hospital, for him, if data is offered to the third party, he has nothing to gain. But if it creates an issue, then he will has to bear a very serious responsibility. So that's why the hospitals are very close and they are very reluctant to offer data nowadays for research, and that slowed down the speed of innovation. And therefore, what companies are looking for is predictability and also the consistency among different regulations, as well as the trusted, the middle parties. And so let's take a look at the advanced countries like EU, Finland, and Japan. And they have the EHDS data space, and they also came up with the regulations for the secondary use of AI data. And also they pursue the pseudonymization as well as the minimization of the approval process. So basically, they have an opt-in system. So unless you specifically mentioned that you don't want, then you will be opted out. But otherwise, your data will be used for research. And I think one of the advantages of the system is that you can secure a large amount of data. And also, you can see that. So for the genome data, they would have the roadmap for the genome data and so on. And for Finland, they enacted the dedicated legislation and established the FinData, a public authority that provides the one-step review and approval for the use of health and social welfare data. And Finland has also been operating a direct institutional permit model, providing access to data at very reasonable fee. In Japan, they have very solid legal basis for the use of pseudonymized medical information. So they enacted the Next Generation Medical Infrastructure Act in 2018, and then it was amended in April 2024. And government certified operators, they serve as the trusted intermediaries between hospitals and researchers, therefore reducing the legal burden on hospitals. And as for the US, so they enacted the 21st Century Cures Act, and previously they also had the high-tech medical law. So they provide the reimbursement to physicians for AI use, and also data quality is assessed. And if data quality is maintained, then that fee is continuously provided. Otherwise, the reimbursement will be stopped and denied. So basically, at first, they tried to expand the bases and the uses, and then later improving the quality. And also the AI so far that we have used so far, they tend to have a kind of discriminated type. So for example, like for a patient with the depression, the AI can predict whether the disease will become incurable or not. And or the AI can predict the possibility of occurring the myocardial infarction. But now the AI model is changing to a multimodal, multi-foundational, multi-purpose model. So which means that it is used for various purposes. So for one data, we use that for multiple purposes. So for example, like data for reasoning, can also be used for other purposes with the different modalities. So however, there are three essential prerequisites that must be met before generative AI can be applied to healthcare. First of all, we have to have a large-scale, multi-institutional, multimodal data, and also data have to be curated and cleansed properly. And also, the visual grounding and explainability has to be secured. So we have to have the holistic approach. So I talked about the Tesla, and I think the Tesla is doing really an excellent job in creating such a closed loop structure. So the Tesla car has 8 cameras, and so starting from 2016, all the Tesla cars do have the 8 cameras, and these 8 cameras are gathering information with the standardized formats. So data is being accumulated, and with this data, they came up with the visual foundational model, and then they have a shadow mode, which means when we drive the car, AI, although it does not drive, but AI actually assess the human drivers driving. And although they don't put its hand on the wheels, but the AI actually gives assesses the gap between the human drivers driving and AI's driving. And it can actually provide benefit to the car users. So the car users actually pay to provide the data, and that data is used for research. And also, the Tesla car assess the score of the human drivers, and nowadays the model is trained only with the data with the high score drivers. So I think establishing this kind of pipeline is very important. So we talked about the data acquisition, cleansing, training. So if everything is done manually, then it will be very least productive, and therefore creating a pipeline is important so that this could be done automatically. And also visual grounding is important. So for example, like let's say that you have the findings from the X-ray, then the visual grounding will give you the visuals to point out what's the problem. And this is the M4CXR, which is a Korean generative AI model for chest X-ray. So using this, if you read the chest X-ray, then the hallucination rate is only 0.2%. So previously the hallucination was a big issue, but now we have a lot of techniques to reduce and minimize the hallucination. So unlike the past, the performance is improving a lot. And also, so for example, like we used a technique called lag or various prompting method. And also you can see that the speed is really fast. So it takes only less than a second for interpretation of one chest X-ray report. And some hospitals, they sometimes they don't have radiologists, especially the small scale hospitals. So however, you can see this solution, the M4CXR, it achieved the concurrence rate of 96.6% with a radiologist, which means that it can be used very usefully for small-scale hospitals. So this indicates a great paradigm shift that is actually happening in Korea's real-world clinical settings. So one of the biggest difficulties in Korea is the data access issue. So that has to be improved. And also we have to have a clear evidence for the secondary legal basis for the secondary use. And also third, we have to mandate the use of KR core in national R&D and public sector projects, and also strengthen EML certification standards. And it should be we also have to use widely standardized SDKs across the industry. And third is the quality So we have to, so if you assess the quality of each of your data, then that will be best. However, that's not possible, that's not practical, and therefore we have to have a rule-based national level clinical data quality indicators. So for example, like the disease that can never occur in females or the males, so this should be filtered out, and we actually have the filtering technique that's already available, so this should be taken advantage of. And also we can monitor and assess the data quality with the data quality indicators. So as I said, these tools are already available, but they have to be adopted more widely. And also we have to build an infrastructure and test bed. So we have to cooperate with the government to expand these spaces. So here also you can see that we have to have the clear rules and also the trust and also cooperation between different departments. Now, at the center of all of this innovation, I think that the HIRA's role is truly critical. And HIRA is uniquely positioned with the Korea's most trusted data base. So I think that they review around 3 trillion cases of the claims data every year. So they do have the huge amount of data, and a lot of data is under review by HIRA. And these data are highly trusted. So HIRA is the trusted data steward. And also, HIRA conducts a scientific review for the reimbursement decision. And as I said, they have the claims data, 3 trillion cases up to per year. And these data have to be shared with the researchers in order to produce the real world data. And also interoperability for code and the EDI right now, it's the de facto standard in Korea. So HIRA is the pivotal institution, I think, in building a trusted database. So HIRA's role will be so critical in driving Korea's into a more with a more sustainable innovation. So here you can see the AI is exploding rapidly, and we have to make decision whether we will be follow or whether we'll lead. And so now we are at a crossroads. And as I said earlier, Korea does have a lot of strength, including the strong data repository and strong data access, but strong data repository. But we still have a lot of bottlenecks. So I talked about the 6 bottlenecks we do have, and these have to be overcome. And in doing so, I think HIRA is truly a very critical and important organization. So we have data and technology already in place. And so let's march toward together.
네, 교수님 발표 잘 들었습니다.
Thank you very much, Professor. So we already have the data, already have the technology. Our role is to make it flow in a safe and efficient way. Thank you for that key message. So now let us move to the third presentation. Director Klaus Muldrup of Data and Data Analysis of Danish Medicine Agency will be presenting. The title is The Use of AI in Medical Regulatory Processes by National Competent Organizations in Authorities in EU now and in the future. Please welcome him with a big hand.
So thank you very much for inviting me for this symposium. This is actually my 3rd time in Korea over the last 2 years. And I'm delighted to be here as a honored guest for the HIRA Symposium. I have been visiting HIRA for the last 3 times here, so it's a very good cooperation that we have. And I would say that I do visit both hospitals, HIRA, the MFDS kits and so on. And I'm always very impressed with what you're doing here in Korea. So thank you so much for inviting me again. My name is Claus Moldrup, and I'm the director of the Danish Data Analytics Center at the Danish Medicines Agency. And as part of that, I am also a member of the Darwin EU board. As you already heard an example of that in the previous presentation, Darwin EU is an OMOP system of a lot of data in Europe. And I'm also the member of the Network Data Steering Group in the European Medicines Agency. So that is my background for being here today. I will start out by looking at, you could say, the European landscape. The basis for my presentation will be this AI Observatory report that we did in the European Medicines Agency together with the heads of the Medicines Agency around of Europe. So that's the evidence for this presentation. It was conducted in 25, but released here in May 26. So what I will do today is I will bring a perspective on how regulatory bodies are using and looking at AI. So far, you have heard most from, you could say, the academic or from the policy perspective. I'll actually be a little more hands-on and give some practical examples of how we do it today and where we are moving. So as a regulatory body, you can actually look at AI from two perspectives. You could look at it as an object, which means it could be an AI-enabled medicine or medicine technology, or the evidence that is used to get a new product on the market. So that's where we tend to look at AI as an object, where we assess the validity, the bias, the risk benefits, and the value around this object. So that is one way to look at it from a regulatory perspective. The other way is to look at AI as a tool, where we use it ourselves as an assistant in how we do our work. So that is where we are looking into how can we retrieve data, review data, prioritize, and so on using AI. So that is where we are looking more into the accountability of the tool we are using, how we audit, secure, and how we make sure that humans are still in control, even though that's also an issue, as you just heard Stephen said. But we tried at least to be a part of it. If we look at it firstly from an object, so where we receive something as a regulatory body, where AI has been applied, where we need to take that into consideration in our assessments, we see a lot of areas where the pharma companies and the medical device companies now are using AI as part of their process when they want to get a new product on the market. In discovery, as an example, targets, toxicity, and biomarkers, that is an area where we see this is being used. In the more clinical setting where you want to do your clinical studies, selection, imaging, endpoints, in silico trials, and so on are being used now. And then, of course, when you look at manufacturing, which is another crucial part of accepting a new drug on the market, there is a lot of areas where they start to use AI models in the pharma industry. And then, of course, when you then go to the post-marketing area, which is where the real-world evidence and so on is coming in, signal detection and so on, that is also an area where we start to use some of the same methods as they use in the industry. What we have seen during the last very few years is that the dialogue with the industry starts very early, even before the formal submission. So the industry is also, of course, eager to know how to react in this AI world in order to make sure that their products can be approved when they have been using AI models. So in Europe, we have the AI Act, which is a very substantial act that is trying to regulate all the use of AI. And of course, there is a lot of questions around that when then the pharma industry is using AI for their different kinds of submissions. On the table on the left side, you see some of the stuff that has been in dialogue with the EMA for the last few years. So when we now move for the remainings of this presentation, I will move away from what the industry does, which also means that I will move away from seeing AI as an object. Now I will move into seeing AI as a tool. And here you see two perspectives. You see the medicines authorities, like the one I'm presenting, how we look at AI, but there is also the payers and the provider perspective on how AI is having an impact on your everyday life. What is evident here is that we have a shared challenge, and that is the evidence that is created around this is changing after market authorization. So when a new product is coming on the market, there is always a change in how we see this and the evidence around it when it's on the market. And that is, of course, important to have in mind. From the medicine authority perspective, we always ask ourselves, can we trust the regulatory process if AI is used for the assessment? And I will give you a practical example of how we are utilizing AI in assessments when we come to later in the presentation. So we can assess both research and development processes. How were they done? Are they compliant to the rules and the guidelines around how to submit a new dossier for new medicines? But we can also, of course, look at the authorization data, the manufacturing quality, and in the end, look at pharmacovigilance. And that's another area I will show you an example, a practical example from. So we look into, can we actually trust AI in the assessment process? But from a payer and provider perspective, I would say that the perspective is a little different. Can we then trust as a payer and a provider, can you trust you could say, the decision making that AI is providing? So when the drug is on the market, can you trust AI when you're looking at access and reimbursement data? When you look at the appropriate use of the medicines, the quality of care, and the real world value. So you are more in the end part, where we are more as authorities, more in the, you could say, the assessment part. And this shift on using AI is already under its way. So I would say that what we see right now is that AI is moving from experiments and you could say pilots, where we observe and assist. We use it for knowledge mining, for drafting and summarization, and also to some extent for automatizations in our administrative work around the assessments. But we are going more and more into the, you could say, to decide, so creating evidence, to continue monitoring stuff, and of course also having, you could say, regulatory graded decision support, so that we are actually using it as a part of our assessment, you could say, work. So that is definitely a change where we will see it in the future, that the infrastructure of AI will become an inherent part of the regulatory system, rather than just something which we try to work with. So this first wave that we have seen of different kinds of AI tools has been for knowledge mining, so that we can search and extract information. It has been more to extend the personal productivity, so use it as draft and summarize and compare documents and so on. And of course, to some extent, also quality assurance, making sure that the documents that we have are in line with the guidelines and the legislation around submitting documents from the industry to us. We have established what is called Scientific Explorer, which is for the national competent authorities to use when a new market application is coming in. The assessors are then using that to also see if the scientific background behind this is sound and if there is any prior cases that they could lean on. And we want to apply a risk-based control model where we keep human in the loop. And again, as Stephen said, well, humans makes errors as well. So it's not, I would say, a way to say if humans are there, then we are good. I actually, to my employees, always apply the rule saying that you should only use AI in your work if you use it in an area where you're already an expert. If you use it in an area where you don't know nothing, you cannot, then it doesn't matter if you're in the loop or not. So if you're an expert already, use it, and then you can hopefully see if it makes some hallucinations or false positives or mistakes. So of course there is a risk-based approach in those areas where the risks are low. So that will be for search, for translation, for formatting. Well, you need a simple check. And of course it's easy to scale this very fast. Then there's a medium risk. That's where you try to summarize or extract or do prioritize based on an AI model. And here we definitely need a continuous review. It should be mandatory and again done by someone who already knows this field very well in order to say if it's good or bad. And then of course there are the high risks where we start to interpret and do decision making and do recommendations. That is where we, of course, are adding a new dimension of, you could say, that the AI suddenly becomes something that is suggesting stuff to you. I mean, nowadays, you could use AI, take a picture of yourself, then say whether or not this suit you are having on is looking good or bad. And it's coming back with recommendations on what to do, but it's not a human. So it's doing this on behalf of a model that I don't know. It might even be that the model behind this suggestion of the suit that I'm buying is developed in another culture. If it's developed in Africa, the way that people tend to like a suit in Africa might not be the same as in Northern Europe, but I don't know because the model itself is a black box to me. So when something is becoming more a decision-making tool, then of course the risk is higher for false or mistakes. And then of course there is a no-go. And the no-go is that it makes autonomous decisions. So it suddenly makes decisions without anything without meaningful reviews, and of course that is prohibited. So regulatory grade AI needs evidence dossier on its own. We need to make sure that whenever we are applying this, we need to generate the evidence that it's actually doing what it is intended to do. And that is within all the areas. So in preclinical domain, in clinical development, in manufacturing domains, in post-marketing domains, and of course also in later stages. So we want to make sure that in order to address this, there has been quite a substantial funding of EU initiatives. The list is very long, as you can see here. All of these areas has been funded by the EU into the academic society, so that big research groups are actually, so behind each of these highlighted programs, there are big consortiums of up to 30 different institutions working together to solve each of these issues. And as you can see, as just an example, Horizon, the first one, is leveraging artificial intelligence for pandemic preparedness and response. So how can we in the future use AI to be more prepared and respond faster? So a research group is looking into that. We also, and this is just a local example, we are now starting to look into how to use AI to predict shortages of medicine. I believe HIRA is already doing that because it's a fundamental thing, but predict the shortages, but also predict what are the consequences of a shortage in one medicine. If that medicine is suddenly pulled out of the market due to problems with productivity or whatever, what will be the consequence for the remaining drugs that could be used instead? What would happen if suddenly another product should be used? Do they have the capacity to upscale? And if not, which patients should have the medicines first and which should not? So we have this in Europe called the prioritized list of crucial medicines. And in that list, we are now making sure that we can, using AI to prepare and understand what happens if suddenly we come short of one of these medicines, both on a local, national level, but also on an EU level. And of course, all this is initiated by the geopolitical conflicts that we see in the world, where production lines of medicine has become global, which means that you might have the API of a product done in China, but the production line might be in India, and the distribution line might be in Europe. And of course, that is vulnerable for geopolitical conflicts. If suddenly we see that there might be some issues and some wars going on that we hopefully not will see, but we are prepared to, you could say, do this within Europe, and that preparedness is based on AI, and we use AI to do this. So as an authority, or you could say as an organization as such, you need to lie the institutional foundations to do this. So we are having these 4 principles: portfolio, visibility. So we are in the European Medicines Agency making a shared inventory of tools and users and accountable owners. So it might be that in Sweden they are developing a new model for, you could say, assessments using AI. Then the Danish authority can make use of that also. So we also need to make sure that we have this granted deployment. So we have a risk classification. We want human to review and secure the operational boundaries, so we control the risk. And then, of course, we need to have performance monitoring. So we need to make sure that the system is doing what it is intended to do. And this is maybe a very important part that I will come into when I give you a very concrete example of one of the things we're developing at the Danish Medicines Agency. And I haven't really heard the word here today, or maybe I just didn't recognize it, but the term black box is very important, especially from a regulatory perspective. So when you use an AI model to give you guidance and maybe even to draft an assessment and then send it back to the pharma company, you need to know exactly on what basis that you could say script or draft was made. Because the company could come back and say, on what basis are you giving this judgment? we need that transparency. We need to make sure that we know exactly what, let's say, 50 documents that this model is utilizing to give this answer, and what 50 prior assessment that this model is using to give some assessment that is in line with prior assessments. And as you know, pharma companies are big, and they're, of course, also relying on a system for the improvements that is accountable and know exactly what it does. And if we don't know that, they will definitely come back hard on us, because we will then come with a wrong judgment based on not knowing what we do. So the black box phenomena is something which is very important. And one of the slides that I can't remember who presented it, said, well, when we use generative models, it's important to know what has been going on. But the case with the generative models, especially the ones that we all rely on, like Chat or Claude or whatever, is that we don't know what's in the box. So I will not ever put anything into that. Of course, if it's materials which have an IP right or personal information, we will never do it due to the GDPR, of course. But I will never put something into that model and then use it as a part of an assessment, because I don't know how it was trained on that specific area. So it's important that what you feed the model with is also the basis of what it is responding with. And then, of course, there is the shared learning part. So we need to learn also from the mistakes, and that is important to scale effectively, of course. So 3 practical routes for international collaboration could be that we, of course, compare use cases. So we shared taxonomy for internal regulation and AI and submitted AI evidence. So we know what's going on across. And I think the knowledge that I share when I have the expert meetings with HIRA or the MFDS or KIDS is a very good example of how we can actually learn from each other between Denmark and Korea. And I'm very appreciative of that. Of course, we could also share assurance methods or validation methods. So what kind of tests and models and documentation and audits can be used to make sure that what we deliver is actually also accountable. And then I think when we move a bit into the future, maybe we could build, when we look at the life cycle of medicine from the very beginning, where a pharma company is thinking about the discovery process and to then maybe, hopefully not 10, 12 years later, but now with the use of AI, only 8 years later, the product is on the market. That life cycle, we could actually maybe build, you could say, a simulation of that and how this product will then be adopted into the society, and then use that as a kind of, you could say, a way to demonstrate how we see this product being utilized as we move on. That could be a very good way to also look at pricing mechanisms, so reimbursement situations. We all know that some of the new products that are entering the market are extremely expensive. Who should have access, who should not? All those kinds of models could maybe be used prior to giving access to the medicines, in order to make sure that we don't put something in place that either are not, we don't have the money to afford it, or on the other hand, we are paying too much for too little. Stuff like that is super important when we're looking into the future. So now for the remaining 15 minutes, I will give you 3 local examples of how we are utilizing AI in the Danish Medicines Agency, just as an example. And it's very different models. One of them, which is very busy but should be quite easy to understand, is, you could say, an administrative tool. So we call it AI DXP, so AI-assisted good whatever practice in life science. It could be manufacturing practice, it could be good production practice, it could be good pharmacovigilance practice. The idea is that each domain, so let's say we have 15 different domains in the Medicines Agency. So we have pharmacovigilance as a domain, we have control as a domain, we have licensing as a domain, we have assessment as a domain. Each domain owner, the area owner of that, the expert within that area, is providing the necessary tools to the AI domain. So all the regulatory knowledge which need to be included, they know exactly what knowledge is the needed knowledge, which one of the different guidance and directives and regulations are the newest, and they provide that to our AI engine. Then they also provide internal knowledge. It could be our standard operation procedures, regulatory procedures as such, templates for the assessments and so on. So that's internal knowledge needed. And then, of course, we have the precedence layer. What has been done before in this area? How does good look like when they perform an assessment or whatever they do in that area? So all of that is, of course, the last one with the precedence area are confidential. So everything here is in a closed environment. So what we do with the AI DXP is that we have taken a lot of the larger models, downloaded those into a closed system. So we are using Llama, or we're using some of the Claude settings and so on. So that is now in a closed system. Then we upload these documents from the domain expert, and from now on, we prompt it only to look in those documents and nothing else. So whatever it does, it can only be utilizing exactly what the expert has told it to use. So that's where the black box phenomena is important, because now we know exactly on what basis it is drafting assessments. So we get a company report. That company report is also uploaded in the system. And then the assessor can ask, okay, to what extent does this report comply to the guidance on how this report should look like? And then it will come back with a draft on that. Or they could prompt it to say, to what extent do we have the data needed for this and this and this? So it will mirror the company report against the knowledge, the internal and external knowledge layer, and the prior decisions that was made. Then it will come up with a draft report. And then from that on, it is the human who, or the expert, who is then structuring and also rewriting it and giving a final response to the company. So this is how we have started. It's still in prototype, but this is how we've started this. We do this within quality assessment at the moment. So huge reports from the pharma companies coming in on the quality, on how they produce a certain medicines, and then the quality assessors are using this to come up with an idea. One of the major issues with this, and this is back to cost, is that to do this, we have our own GPU. So it is extremely expensive to have your own supercomputer running doing this. So of course, that is one of the major issues with this, is that in order to do this at the Danish Medicines Agency, we are 600 employees, 650 employees. And if they should all have access to do this continuously, then this is a big cost. So that's one example of how we use it for an administrative purpose. The other one, I think I actually showed this 2 years ago also when I was here, but now we are a bit closer. I would not say as close as I hoped for, but a bit closer to the real world on this. This is pharmacovigilance by AI in real time, a project called FAIR. So what is the biggest issue with pharmacovigilance is that a lot of the side effects that are in the real world are not reported. So we don't know about it. Let me give you an example. A new medicine for epilepsy may be on the market. And this is just a imaginary example. This new medicine is given to new patients. And suddenly a young woman is coming to the doctor saying, well, suddenly I have some hormonal changes. So the doctor says, okay, we'll write that in your journal, the medicine journal. I don't know what it is. Let's see if it continues. So it's not reported. So there's no, you could say, you got this new medicines for epilepsy, and maybe it has an association with your hormonal changes. So nothing happens because we don't get the knowledge. The authorities on side effects has notoriously been, you could say, reactive. We are only handling stuff that we get an action on. And in this case, maybe then suddenly one doctor is saying, okay, maybe it has to do with this new epilepsy drug that you got. So he's writing then a side effect report on this. And then we get to know it. And usually we will then sit on our hands for the next 5 years, wait until we have 20 reports of the same. And that, of course, is not very good either for patient safety or for an effective healthcare system. So with the FAIR setup, where we have access to all health data in Denmark, all the medical journals live, we have now set up a system where we can actually search for, you could say, identical cases. So there is a lot of free text in these medical reports. And suddenly, if we say, okay, can you find similar cases? Could you find a digital twin of this young woman who just got prescribed this new epilepsy drug, and where the doctor might have said something about hormonal change in their notes? And suddenly we might find 10 or 15 cases that was not reported. And that is why we are becoming more and more proactive in our way of finding and finding potential side effects, and then hopefully also validating them afterwards. The last case is you could say a risk reduction case. Also in this case, we are looking to become more proactive than reactive. So in the top, you see a traditional approach to medicine, to a patient treatment. So you get a diagnosis, then there's a treatment decision, you get treatment A. If it doesn't work, then you get treatment B. If that doesn't work, you might even end up getting treatment C, and so on. Everyone knows that this is not the way to do it, but this is just how practice is today. And then, of course, for a very long time, stratified medicine or pharmacogenetics and so on has been kind of something that everyone was talking about. How can we do a generic test first and then give the right medicine to the right patient at the right first time? But I mean, I was doing my first reports on this when I was a professor at the Copenhagen University back in 2001. So that is 25 years ago. And to be honest, nothing has really happened since then. There's a few genetic tests within cancer and expensive medicines, but what about the more common medicines? I mean, this is going on in every area. So at that stage, I actually proposed a research program saying, okay, we have all this real-world evidence on the medicines. Why don't we go the other way? Instead of looking at genetics, why don't we look at real-world evidence and then deduct from there? Because if we have, let's say, 20 years of practice with a certain medicine, and we know exactly who's shifting from one medicine to the other, could we use that to actually identify why they did it? Or are there any common associations between those patients? At that time, it was maybe wishful thinking because we didn't have the computer power to actually do this substantial work with all these data. But we have now. So we just got granted a huge grant from the Danish government to do this, and we will do this within 12 very common treatments. We started out with metformin, very known medicine, been on the market for a lot of years. No substantial side effects as such, and people can switch. So why look at this? Well, there's a lot of patients on it. And why? So the magnitude, it might be a cheap drug, and it might also be that the side effects are not that severe. But when you add it up and have 100,000 patients on the treatment, then suddenly it is a big burden to the healthcare system, because every time they need to change their medicine, they need to see a doctor. So there is a lot of money involved in this, but there's also a lot of destiny around these patients. Why should they start on one product and then leave for another and another product? So what we're doing now is that we essentially do exactly as we have always done. You do a diagnose, then you get a disease X, and then we do the stratification based on big data instead. So the example with the metformin, we know that 10% of all the patients who get prescribed metformin, they will stop before 90 days. And then you can ask, why is that? Well, essentially we don't care. What we care about is that they need to change their medicine. So we use AI now to identify what common things could be a determination or determinator for the doctor to actually then prescribe differently and start with treatment B. It could be simple things as, okay, a patient who has metformin type 2 diabetes, they're usually up in the ages. They might even already have 5 or 6 other drugs that they need to take every day. So it might be that simple things like the adherence around this medicine is too difficult. So if that's the case, and we identify that 80 or 90% of patients who stop using metformin also are using 6 or 7 other medicines, then the doctor could say, you should have metformin, but we know that 90% of you are stopping because you already have 6 or 7 medicines. So I will go to once weekly treatment up front instead, so that we hopefully get a better outcome and you won't stop within the first 3 months. So the takeaway here is that the future authority is not an automated, but it is an augmented and accountable authority. Hopefully, we will retrieve and process faster. We will be better at testing and explaining, and hopefully we will also be wiser and learn from our decisions. So human judgment, and back to the idea that only use AI when you're an expert already, needs to be the accountable layer from an authority perspective. And of course, we should widen the attention and strengthen the consistency, and also, of course, shorten the learning cycles. So, 감사합니다.
Thank you very much for your meaningful presentation. 네,
So he shed light on the cases of the European countries. Once again, thank you very much for the presentation. So with this, we are now finished with the third presentation. Let us move on to the fourth presentation, which will be given by Director Lian-Yu Chen, Director General of National Health Insurance Administration of Taiwan. The topic is maximizing digital technology in Taiwan's NHI. Please welcome her with a big hand.
지금 기관장님 자리에 안 계실까요?
So I believe the Director General is not in the room. Oh, she just walked in. Please welcome her with another big round of applause.
클리커 전달. Yeah, floor is yours.
Okay. Good afternoon, everyone. I am Dr. Liang Wuchen. I'm the Director General from National Health Insurance from Taiwan. It's my great honor to receive your invitation to participate in this international discussion on how does AI transform healthcare system in Taiwan, in Korea, in many other countries. And does AI augment or replace medical practices, clinicians? And does AI help or sometimes intervene? And that's a very interesting question. And thank you again for this invitation. And it's my great honor to learn from the best in Korea and also from the international scholars. I am a psychiatrist by training. Very early in my career, I went to the United States to train my public health, to get my PhD in School of Public Health in Hopkins, and then came back to start my career in Taipei City government and move on to National Health Insurance Administration. But that's not related to today's topic. So I learned that I have 40 minutes, and I will start to talk a little bit about the Healthy Taiwan policy, about 5 to 10 minutes. And then I will talk a little bit about how we utilize digital innovation in national health insurance system and how we deal with our challenges from chronic illnesses. One of the program called AAA program, that is our national policy for the management of the 3 highs: hyperglycemia, hypertension, and also hyperlipidemia. And then we will share out a little bit of our experience on our cancer moonshot. And then we will talk a little bit about the experiences of the digital infrastructure over the 31 years in Taiwan in our national health insurance system. Apologize for the shortness of breath. I just came from, I just arrived Korea, and thank you again. So actually, the national health insurance system in Korea and also in Taiwan have a lot of similarities. First of all, both of us are single-payer system. And then I realized that Korea start first. And then Taiwan started our national health insurance in 1995. So actually, this year marks the 31 anniversary of our national health insurance celebration. However, we start with a single payer system and uniform package for all workers, for laborers, for farmers, for government officials. And within my knowledge, Korea started later on to have a uniform healthcare system with similar package. That is the different strategy development in the history of the 2 national health insurance systems. So some of the similarities, both of the systems have high universal coverage. In Taiwan, it's about 99.9%. It's so far the highest in the world, with the #1 ranking in Nobel Health Index for 8 successive years. And it's a comprehensive benefits, cover from cradle to tomb, from prenatal examination to hospice care. Financial protection for the low-income family in Taiwan, starting 10 years ago. And then with the high equity, high medical access, that is well known in the world. And then today's topic is to share our digital infrastructure and our lately how to utilize the digital innovation on our policy and also for our patients. I share this graph a lot starting last year. So Taiwan has officially entered super age society last year in 2025. Globally, there are only 2 countries went from age society to super age society in 7 years. That would be Taiwan and Korea. Yeah, I saw a lot of smiling. Yes, so that's great challenges. And if you look at the graph on the left side, hope that's clear. Here. This orange line represents Taiwan, and then the blue line represents Korea. You can see how steep the slope is. So Taiwan and Korea are among the world the fattest Asian population in the world. And if you look at Japan, is here. So as a country, Japan aged earlier, but not as fast as Taiwan or South Korea. So that poses tremendous challenges to our healthcare system and, of course, to our national health insurance system, as South Korea and Taiwan built in very similar fashion when we are trying to design our financial infrastructure of our healthcare system. Then, if you look at the right side, here I said disability. Actually, there are people who need a long-term care. So now it's 2026, and within our estimation, when it comes to 2031, we will have about 1.2 million people who need long-term care services. And among them, about 0.85 million people are age population, indicating they are age 65 or above by the definition of WHO. So you can see that's pose a tremendous challenges to our healthcare system, to our long-term care system, and also to the financial stability of our health insurance. So both, again, South Korea and Taiwan are super aged society, and we age so quickly. So they pose challenges to our healthcare system. First of all, financial impacts, as you can all imagine. So we have our challenges, and also we have our strategies to deal with the financial challenges. And the second, we will talk about a shortage of manpower. Taiwan, like many other countries, are facing a shortage of manpower, particularly nursing manpower. So nurses are leaving their workforce. So starting last year, we greatly invest in the payment, and we asked the hospital to pay higher, and then higher and higher for our nurses on the working environment. And third, the geographical barriers. I will talk a little bit about that here. As most of the medical services are located in urban areas. So as the population age, people start to move from rural areas to the urban areas. What happened to that is that with our health insurance design, by pay for services, the local clinics or community hospital will not survive financially if they earn their payment from national health insurance with the design of pay for services. So we need to greatly change the way we pay the hospitals, pay the medical doctors. So that's why I talk a little bit about that there. Then that's a similar situation within my knowledge with Korea. And also the increasing burden of chronic diseases that, of course, are challenges for whichever society which are super age societies, the three highs. So Taiwan has 23.5 million people, with among them about 5.3 million people has three highs. But for those elderly population, 70% of them have two highs: hypertension, hyperlipidemia, high blood sugar. So 70% of the elderly population have two highs. That's how serious that is. So I don't know the detail of the data of Korea, but we can talk about that later. So our current president, Lai Ching-te, he's an internal medicine doctor and a nephrologist by training, and he has a remarkable, unique pathway becoming a politician and then becoming our president. But because of his unique training, earlier in his career, he invested greatly in our healthcare system, including our health insurance system. So here's the Healthy Taiwan policy. That is a bottom-up recommendation from a group of medical health professionals, experts, leaders in 2024. They formed 10 recommendations to the government. So after our President Lai become our president, he changed that initiative to official committee and then made these 10 bottom-up recommendations into policy. So these 10 are, improving the working environment for health professionals. Rule number 1. I believe that's a similar situation here. Rule number 1, trying to improve the working environment so we can still attract young people to become, our healthcare frontline workers. And mental health support, our AAA program for chronic illness, cancer drug fund. So Taiwan established the very first cancer drug fund last year in Asia. And then to increase the NHI global budget, it means for our financial stability. So he gave us more money for the healthcare system and so on and so forth. If you look at number 8, that is to accelerate the integration of smart healthcare and health services. So that will be the topic of today. So daily is the disability adjusted life years, usually commonly used to measure healthcare burden, health burden in the field of public health. If you look at the data in Taiwan, number 1 cause of death is cancer. It constituted about 20%. And number 2 is cardiovascular diseases. Number 3 is diabetes. But if you look at the finance infrastructure of national health insurance system, on the bottom here is Taiwan's medical expenditure on 3 high-related diseases. So not just 3 highs, but 3 highs cause of morbidity and mortality. If you look at them on the top 10 diseases that cause most in our system will be, for example, kidney failure, diabetes, hypertension, ischemia heart, stroke. So among the top 10, 5 of the diseases are related to 3 highs. That's why cancer and also 3 highs are among the top national health strategy in our Ministry of Health and Welfare in Taiwan. So this is a brief introduction of the AAA program. It will take a little bit of the time to explain what is called Family Physician Program. In Taiwan, our healthcare system does not have a gatekeeper. So you can go to see any specialist as long as you can make an appointment. You don't need to be referred by a GP. However, that does cause increasing health burden and medical expenditure with the kind of design. So we have a program called Family Physician Program, and then we have a platform trying to integrate the different payment in our national health insurance system. So we can clearly see how much money one patient costs on what kind of medical services, trying to integrate all this payment through different programs using the Family Physician Program. later on, maybe we can develop something similar to Singapore with a gatekeeper system, but that's probably in the future. So the first 80% is that we would like this family physician program to cover 80% of our 3-high patients. The second is that we would like our patient to receive lifestyle intervention, not just medical treatment, but lifestyle intervention, including exercise, your nutrition advice, and suggestion to help you to quit tobacco or alcohol, things like that, lifestyle intervention. As we know that 40 to 60% of the chronic illnesses are from lifestyle, not just from the disease itself. And the third aid refers to fair control for the 3 highs. So this is the AAA program. And this is the My Health Bank. Within my knowledge, the Korea healthcare system has similar app in this country. And then we have My Health Bank app in 2016. So far, half of the population has downloaded. About 1/6 of the population constantly use this app to check on their data. Here you will see we asked them to answer 22 questions about their lifestyle, including nutrition, exercise, sleep, whether you are socially isolated, 22 questions. And all the data will be stored in the My Health Bank. So our patient's doctor will be able to see all the data. We started this lifestyle intervention last year, and that is a great step for National Health Insurance Administration. Why did I say that? Usually the healthcare system data is claim data. So we have the payment data from the medical provider side, but we do not have the data from the patient side, the user side. So with this, first time we have the data from our patient side. Why do we need the data? Because we want to better our healthcare system. We want to better our reimbursement system. And then we want to design better public health policy for our patient and based on our data. So now inside of the National Health Insurance System, we have gender, age, family history, lifestyle data, everything there. And then we have the National Health Insurance Cloud starting in 2013. So everything is stored in our MediCloud. And then we will be able to use the big data analytics. If you call the AI, you could probably say, okay, this is a big data analytics to stratify our patient into different risk sets. For example, for diabetes, you might have a patient who has very stable condition under fair control with drug refill every 3 months. But you may have other kind of patient with severe complication and will need services from medical centers, not just from local clinics. So then we will be able to design our reimbursement system in our National Health Insurance system. And that is the lifestyle medication, lifestyle intervention questionnaire I mentioned. So as here, you will see after our analysis, then our patient will be able to get the data of their risk stratification on the app. For example, for the lady, what's your comorbidity analysis? What's your severity of your, for example, renal failure? What's your risk for cardiovascular diseases? So our people will be able to read all this risk assessment through the app downloaded from National Health Insurance Administration. And so that's our first time and also Google's first time. With that, we collaborated with Google, and I guess that's part of the reason why I am invited here to share the experiences. So we have the social demographics data in our National Health Insurance Administration. We also have 31 years of the medical service data, diagnosis data. And starting last year, we have the data from the user side from their lifestyle. About half of our 3 high patients have answered all the questions, the 22 questions with their exercise, nutrition, their social isolation. Then we partner with Google and we analyze our model called the AI on diabetes. We start with diabetes because that has a very clear biomarker with glucose, AC, PC, HbA1c, and so on and so forth. So we start with diabetes and trying to run the model based on the patient's data to assign this patient into different resets of diabetes. And now we are in the process of running the data for the other 3 highs. So Geneva, so this year in Geneva, Google helped Taiwan to share these experiences inside of WHA. And then the lady next to me is the genius engineer from Google. She's the lady behind the Gemini. I saw the laughing, yeah. Then after 3 highs, I will talk a little bit about cancer and how we utilize digital technology to better our cancer treatment. So here is, as you can see, we have cancer as a leading cause of death for more than 44 years. With breast cancer, the green line represents breast cancer here. It grew so fast, it doubled in 2 decades. And then the left side represents the 5-year mortality rates. So we have the Taiwanese cancer moonshot plan. The first strategy is to greatly expand the cancer screening, starting last year. And second, we pay for genetic testing, NGS. Third is we established the very first cancer drug fund in Asia. So that is the stage of cancer diagnosis. The data is not pretty, but here I just want to show you that in Taiwan across the years, if you look at the blue part, even now, more than 40% of the firstly diagnosed lung cancer are stage 4 cancer patients. That's why we would like to greatly increase the cancer screening program, trying to identify our cancer patient as early as possible. And that is our investment. We increased the cancer screening budget up to 2 and 5 times compared to the original budget. And that is, NHIA is also paying for next generation sequencing. Within my knowledge, the Korea healthcare system, insurance system also pay for the next generation sequencing. And we utilize this data, everything in NGS is on FHIR format. And also for our cancer drug fund, everything is built in FHIR format. So the data in different hospitals will be able to talk to each other with great interoperability. That is cancer drug fund, that's just a progress. But for today, for this topic, the most important thing is that we have another administration called Health Promotion Administration that is responsible for cancer screening. And our organization, National Health Insurance Administration, is responsible for treatment, for NGS payment. So all the data are in the process of integration. And then for the new payment, everything is built on FHIR. So we are in the progress of building the national cancer treatment data in FHIR format. And that is a whole person colorectal cancer care. That's just an example because we have linked it. We have integrated data from Health Promotion Administration to NHIA, the healthcare system. So we have screening data, and also now we have treatment data. So nationally, we will be able to see, okay, 5% of our colorectal patients who have definite diagnosis from the doctors did not receive later treatment. So that is how we trying to identify them earlier and trying to encourage them to receive treatment as earlier as possible. It's also part of the cancer moonshot plan. And this is, again, I will show you My Health Bank. I know that you have similar app. And now the cancer screening reminders is all on the app, and that is personalized and designed using the patient's data, and will remind the patient, hey, you need to go back to see your cancer screening data. And for those who discontinue their treatment, they will also see the reminder trying to remind them to go back to see their doctors. Okay, then comes to the digital transformation. That is the way our health insurance IC card look like. We have National Health Insurance IC card in 2004. We start with very simple 6 domains. For example, treatment visits, drug prescriptions, allergies, whether the patient will receive palliative care or DNR, starting in 2004. Then we built the MediCloud system in 2013 and greatly increased the digital infrastructure. So now we have diagnosis, prescriptions, allergies, and then in 2019, we also connected data from CDC to NHIA. So then in 2020 and 22, as you all know, that the pandemics of the century, COVID-19 hit the whole world. So back at that time, during COVID-19, Taiwan is one of the few countries had the national data and with the medical services, allergy, diagnosis, and also the patient received first dose of COVID vaccination, second dose, third dose, and will be able to analyze everything using our NHIA data. Now, as I just mentioned before, we are trying to further incorporate the data from cancer screening, all the screening data. So not just vaccination, but also screening data will be inside NHIA, and then have lifestyle data, including nutrition, exercise, social isolation, 22 questions answered by the participants. And right after we introduced the MediCloud system, our duplicate examination decreased for more than 30%. Our duplicate medical examinations decreased for more than 60%. Then it greatly saved money, so we will be able to save this money and then to further invest in those novel treatment and novel technology. And this is our virtual IC card. I realized that Korea has similar thing. So we developed that in 2019. So during COVID-19, you will be able to send a request to the hospitals. And then the patient will say, yes, I agree that doctor will be able to see my data in the MediCloud. Then you will be able to see the patient without really going to go to the hospital. So that is the total solution for the barrier-free medical services. We're trying to develop that system right after COVID-19. Here you will see, this is the virtual IC card, and then you can use telemedicine to see your patient or to see your doctor. And now we are trying to build an e-prescription program. Up to, by the end of this year, about 1,000 community drugstore will implement the system. So far, most of the medical centers in Taiwan have the system already, but we need the community drugstore also implement the system. So the patient will be able to see the doctor using their cell phone, and the doctor could access the patient's data in the MediCloud, and you will show a QR code on your cell phone, and you can just go to the drugstore next to your home without really going to see the doctor, and then everything will be done by e-payment. So that is a press conference that you will see me and also the dean for National Taiwan University Hospital. So we announced that and trying to greatly implement that program to other rural areas, because those underserved areas are the places that need that most, with the barrier-free medical services, using everything telemedicine and also e-prescriptions. And here is telemedicine in remote areas. Starting last year, we pay for all the consultation or the medical consultation in remote areas and also for island nearby Taiwan. And that is a question probably some of the pharmaceutical companies or AI companies are interested in. How do we decide whether to pay for the AI medical device? That is a question that has been asked by many health insurance companies, public or private. Here, we will decide through the process called HTA, Health Technology Assessment, and that is the very first medical AI that get reimbursement by National Health Insurance Administration. That is a AI monitoring sensor. They can detect the hypotension during operation 15 minutes earlier. So that is the very first medical AI that our system pay in Taiwan. And we have a MOU with NICE in 2023. That's the first time we signed the MOU, trying to train our personnel, our government officials, and also our experts to learn from the HTA and also HTR, Health Technology Reassessment, to decide on what kind of medical services will continue to stay in the healthcare system, and what that we decided that we will discontinue the payment. So through this evidence-based science method. And then you will see we continued the MOU this May with UK. And then the Taiwan's healthcare innovation on global stage. We do learn a lot from many other countries. We also visit Germany this May. And as you know that in Europe, they adopt the GDPR Act, so all the personal data will be highly protected. So far, Taiwan adopt similar method using GDPR. However, we did visit a lot of countries and learn also from Korea and from many other countries. We trying to learn from the best. If everything follow a GDPR format, then for the company or for the government will have great challenges to obtain so much data. In the era of healthcare, smart healthcare, or you might say in the era of AI healthcare, it is crucial for you, for government to own the data. If you look at the 5-layer cake, the theory by Jensen Huang from NVIDIA, first layer will be energy, second layer will be chips, and Korea and Taiwan, we both own huge companies who produce chips, correct? The third layer will be digital infrastructure, and there will be data and how our regulation, how our laws allow you, government, company, or many other people to obtain the data, how to balance between personal right to protect our privacy and for the government to form policy to gather the data. And that's the dilemma all over the world that we are talking about that. I have no perfect answer, and I believe no one has, but I would like to hear from later on's discussion on your opinion on GDPR and how to balance between personal right, your private data, and also for the public good to obtain the data, even though that's the identify. In Taiwan, by law, our patient will be able to withdraw their data from NHIA. It's guaranteed by our constitution law. So it's always good to learn from each every one of you. And it's my second time to visit Korea, but it's my first time to share the policy in the International Symposium. Many thanks from the invitation from HIRA. And here you will see last year we celebrated our 30th anniversary of National Health Insurance Association. All the previous DG, everyone are there, happily getting together and count our blessings and also reflection and talk about what to do in the future and many things. And that's my last slide. Thank you very much.
Thank you so much for sharing your insights with us. Thank you. 네,
Yes, thanks to Director General Chen. We now learn about the current status of NHI in Taiwan. So we now heard all the presentations of the day. We're going to take a 20-minute break until 4 o'clock. Enjoy the refreshment outside. At 4 o'clock, we're going to start the next session. Come back.
네, 좋습니다.
Did you enjoy the break? So we will now begin the panel discussion of 2026 HIRA International Symposium. The panel discussion will be held for about an hour. So I would like to invite you to engage in this discussion actively. Let me introduce the moderator and the panelists of the session. Please welcome them with a big hand. First, Professor Joo-han Kim of Seoul National University College of Medicine will serve as a moderator. Big hand, please. Thank you. And let me introduce the panelists. Honorary Professor Stephen Duckett of University of Melbourne. And Professor Rae-ung Park of Aju University. And Director Klaus Moldrup of Danish Medicine Agency. And Director General Lian Yu Chen of NHI Administration of Taiwan. And Professor Hong-soo Kim of Seoul National University. Thank you. And Director Jung-hwan Park of Division of Health, AI, and Data Policy of Ministry of Health and Welfare. And Director Moo-sung Kim of AX Innovation Department of HIRA. Thank you. So from now on, I will give the floor to the moderator. Yes, good afternoon. Very pleased to be here. As part of 2026 HIRA International Symposium program, we're having this panel discussion, and I'm honored to be serving as a moderator. We've already heard presentations from 6 different speakers, and 4 of them are part of the panel. And we also have panelists who are newly joining as a panelist for this discussion. So I have a pad in front of me, and if you can upload your questions online, we'll be able to ask them to different panelists. So as instructed, please post your questions online. So as we engage in this international symposium, we heard cases from Australia, Denmark, and Taiwan, and it helped a lot for us in broadening our perspective. And we can now see AI is everywhere. AI is ubiquitous. So AI is everywhere is a catchphrase used by Professor Ronnie Burkis from MIT during the AI winter period. So everyone was asking, where is AI? And he said AI is everything because AI is in the refrigerator, washing machine, and everything. So it's ubiquitous. Now, indeed, in medical field, for regulation, for approval, for insurance, for new drug discovery, and for post-market vigilance, AI is everywhere. And half of the slides seem to be created with ChatGPT. So I thought AI is indeed everywhere. So that was a brief introduction. But if I may summarize the presentation, we do have 4 speakers in our discussion, and Professor Stephen Duckett talked more about regulation, combining theory, practice, and even philosophical backgrounds. And Professor Park from Aju University talked about application of AI in medical field and how to intensify data-driven patient centricity. And the third presenter, who is Dr. Klaus Moldrup from Denmark, talked about AI in the perspective of regulatory authority. So AI is used for new drug discovery, but it's also harnessed in AI in approval and regulation activities. And the Director General Lien Yu-chen talked about national insurance scheme, how big data analytics is in action, and Korea, Taiwan has a lot of similarities. So I think it's basically a secondary use of data rather than primary use of data. So that was a little bit long-winded preamble, and we do have three panelists who are not speakers. So briefly, I would give the floor to the panelists to say their comments and feedback about the presentation. Maybe Professor Kim first. Yes, so speakers already presented, so we're giving the opportunity to you first. So I am Professor Hong-soo Kim from Seoul National. I'm very delighted to be part of this significant panel. From morning on, we listened to the talks of different speakers to talk about AI in healthcare domain. So as was mentioned by the moderator, I think 5 presentations and this 6 presentation talked about the same theme. So we already have the technology, but the bottleneck lies in the institutional system or framework. Regulatory predictability, how can we stratify the necessity of supervision, access and standard for data, and risk management. So risk and governance is one of the most hottest and most urgent topic in AI and healthcare area. So that topic was looked at with greater depth. So one thing I want to mention is value. So risk versus value. So risk has already been talked about by many speakers. And the topic of value also appeared in the presentation of the speakers, but it didn't receive a lot of attention compared to the risk. So I want to focus more on value. Irrespective of AI, the topic of value is very important in Korea and globally alike, and you would agree to this. When we think about why, I would talk about value first and combine this topic with AI. So from a provider's point of view, within hospital, performance are being assessed, and as part of the role of HIRA, the assessment and evaluation have been done very actively, and Korea is leading the wave. So my research domain is aging and AI, and with the burden of aging popularity and chronic diseases, the outcome goes beyond the walls of hospitals and clinical pathway. So researchers are always asking, have we done the right things? And the content of evaluation also changed. So moving from treatment only to the maintenance and management. So the whole journey is considered. And Director General Chen talked about different cases in Taiwan, and for chronic diseases and compromised functionality, cure is not the goal anymore. And the title of medical innovation is responding to super age society and predictive recovery. So we have 10 recommendations. So we are thinking more about value in maintenance and management. And second is perennial topic. It's access to quality and cost comparison and ratio. So goals are the same, but with the financial and talent resources and inefficient resources, the burden is becoming heavier. So structure itself and infrastructure is under greater burden, and we need to identify priority, and it's becoming even more trickier to define priorities. It's not because we are not doing the work, it's because the problem is more complicated than ever before. So MSD's background, AI, was added to the scene. And AI itself is an object, of course, as was mentioned in the presentation, and is being assessed. HIRA is doing that, and digital transformation and other care-related technologies are presented. And Professor Park's talk also included the point that so in order to accelerate innovation and in order to ensure safety and protection of the general public, how we're going to look at AI and objectively assess the value.
Another thing that's important when it comes to the value evaluation is using AI as the tool, and I think this is something that we can delve into. So we have talked about the fragmented care pathway and also the importance of maintenance and also the selection of priorities. So far, it was very difficult to assess them and evaluate. And as mentioned with the Danish case, actually showed us some potential for future. So maybe the HIRA and other organizations, I sincerely hope that they can utilize the AI well to turn this crisis into opportunities. And another important thing is that where we should head toward. In other words, our goal, objectives in the era of AI in addressing all these complex issues. We have to have the risk governance plus the enhancement with values. And we had very extensive discussions. And we talked about how we should manage and govern the risk and what we should avoid. And I think that we actually had a lot of global scale discussions on this topic. And this is something that, of course, we have to think hard about. But another thing that we have to think about is going beyond the risk management. How can we maximize the value of AI? And it is something that the HIRA should also pay attention to. So in this sense, I think we have to have this kind of two-track approach. So in terms of the goals, and as mentioned by the Tsuge, the 7 principles for the fair, I think that that can be a great starting point. But actually, the challenges that we are facing are slightly different. So I think we also have to find our own solutions that fit our situations. So the researchers come up with the idea, they publish the articles. So we are still exploring this topic, and I think this symposium could be a great opportunity for us to think together about this. And although we don't have the clear answer, but I think that there could be some preconditions to be met. So the government cannot play everything, but let me talk about these preconditions. The first one is the issue with when to assess, when to measure. So AI looked at the snapshot and they actually regularly do the assessment. Rather, previously we do the assessment 3 months, 6 months, 9 months. Was there any changes? But AI is like a moving target. So it's very difficult to assess. So, and also our current approach for assessment, is it really the right one in the era of AI? So this requires to rethink about the current approach for assessment. And also as mentioned by Dr. Muldrup, so even for the post-marketing evidence, so that's important. So right now, the evidence is generated mainly before the launch of the product, but real-world data and also the values after the market should be measured, and I think it requires a lot of resources. And also the assessment so should not end with the approval, rather it should continue beyond approval. And also for the episode-based care and reimbursement, let's say that even for the same treatment, it can be effective within hospitalization, but maybe not effective after hospitalization. So, and also whose perspective is this? So we had a lot of discussions, and so the regulators and government, we had discussions from their perspectives, but we also have to think about this issue from the perspectives of the public or people, lay people with not much literacy, digital literacy. Of course, everybody nowadays, they look at the ChatGPT, they use ChatGPT, and they do a kind of pre-search before going to see a doctor. But yes, we have to consider the provider and payers' perspectives, but we should not miss the perspectives of the general public, the beneficiaries. So the goal of HIRA, I think, remains unchanged still. So value-based, outcome-based enhancement. This is something that you have to aim for. But with the AI, I think that there are some flexibilities that need to be adopted. So Professor Park said that the HIRA is the organization that connects the everything together. And so I believe that having a holistic perspective and giving the consistent message is very important. And from that perspective, so AI as a tool and also as an object, I hope that the HIRA can come up with the right direction. So that concludes my remark, my comment. So thank you very much. Now, following that, so in Korea, we actually have the department under the Ministry of Health and Welfare that named with the AI and welfare. So the person from the department. Yes, so I am from the Medical AI Policy Department. So our department has the longest name in the Ministry of Health and Welfare. So I am a data expert, and so I was in the data department, but then recently our department got renamed as the AI Policy Department. So I think it's pretty rare for the Ministry of Health and Health Ministry to have the department with the name that includes AI. So the reason that our department renamed ourselves, so it was as of the July 22nd. And at the time, we had the event under the leadership of the president. And at the time, we announced the AI basic policy and approach. And then on August 2nd, we had another meeting under the leadership of Prime Minister to talk about the AI national strategies. And a lot of things were covered in that meeting. And I think that many things are aligned with what we discussed today. So since we have the foreign participants, I think I should be cautious in talking about the Korean government stance. But I think that this is a very welcoming approach that we go in the right direction. And also, I am relieved that we are not alone in this direction. But at the same time, we have to remember that we are not the only one who drives aggressively. So compared to other countries, again, we have to make sure that the Korean public receive the high quality medical services. And each country, I believe, they have different goals, different directions. But I think that there are also several common denominators. So when it comes to AI, so the technology and how it is integrated with the healthcare system and how it enables the new treatments that are different from the conventional modalities. So even international organizations like OECD, I think that they also pursue in the same direction. So safety is always our priority. But and I think that we also have the common understanding that the safety or efficacy are not always guaranteed. Let's say that you take a drug to reduce the fever, and unless there is a special situation, it will cause a biochemical change in our body to reduce the fever. However, that's not how the AI works. So the context, the individual differences, or the situations where everybody is individual is in, or the relationship between the doctors and the patient. So we have a lot of varieties, and so previously, so with the AI, we have to have different approaches, and I think everybody agrees on that. But deployment is easy and also it's not costly. So let's say for new medicine or the new medical devices, in order to deploy them in the market, there should be some physical transport being involved, and you have to purchase the compound to produce the drug, but it's no longer necessary. So using internet or the network, the information can be shared or transferred from one place to the other place, or only with the computation, the medical AI can work. And therefore, this is a very different aspect from the conventional things.
Taking all this into account, different framework, regulation, and support mechanisms are being developed in different countries in different ways. And the information that we heard today and the trends that we also research for other countries are taking the similar trends. But usually institution-based or agency-based support system and regulation system and on-site governance, data standardization, and interoperability are mandatory, basically. As was mentioned, when there is a set physiological and chemical principles, the application of different rules and policies will be done in a uniform fashion. But when everything is procured remotely and electronically, all the services are implemented, the necessity for standardization and interoperability is much, much higher, but the actual execution might not be as easy as in the past. And sometimes in the context and the on-site delivery of the service by ACP also would sway the outcome greatly, and the decision by ACPs are also very important. So it should not be haphazard. It should be governed clearly in a rule-based fashion and coordinate different stakeholders and all the institutional and governance-wise landscape or the foundation should be built. And that is what exactly Ministry of Health is focusing on, along with the collaboration of HIRA. So that is one aspect of the AI basic strategy that we have ratified in August. So the challenges we might face include, of course, we cannot really base things on tokens or the utilization. The costs will continue to reduce. And from a physician or ACP's perspective, the cost and the value and cost effectiveness can change all the time. So we cannot really incentivize continuous usage of AI. And even when the number of usage increase, you cannot really definitively say it will lead to the benefit to the patients. So clinical outcome or effectiveness need to be quantified, and reimbursement or the payment should be based on that. And that is where a ministry and the HIRA should play a very important role. And this is unprecedented endeavor and mission given to the organizations. And Europe is also facing the same challenges and other countries as well. So I'm looking forward to the discussion and exchange we can have. And finally, in terms of advancement in AI, I believe the government and public sector and related nationally sponsored and nationally state-operated hospitals should play an important role. So that's why the strategy is focusing on public sector hospitals, and the president is also proclaiming active role of government in AI strategy. So AI models will be developed and we will advance the citizen-facing services based on AI, and more efforts are also needed there. We cannot be full with a single spoonful. We will continue our efforts, and that is also part of the strategy we announced. Whenever I attend these kind of symposiums, I sometimes summarize the content of presentation, expressing the gratitude, but the moderator did a wonderful job, so I will just skip that part. And the professor, Kim, also did a wonderful job, so I'm going to make one more comment. Everything is basically a system or institution, and the government policies and institutions should be a lubricating oil that help private sector work as a well-oiled machine. But another important role of a government is to provide infrastructure. Other than the infrastructure, what's most important is hardware infrastructure, network, GPU, and computer resources. So in that aspect, we created a public medical AI highway. So GPU will be provided by the government, and today, we have an announcement about the pilot project. In relation to that, the Ministry of Science and Ministry of Health will cooperate to provide GPUs held by the government or the country will be made available to medical institutions so that they can say we are engaged in AI utilization and GPU shortness is not a hindrance for us. So here, when I say medical institutions, this will include hospitals, and the government will include HIRA and other health-related public agencies. So further exchange and collaboration will be conducted in data. So on top of Korean platform, Korean data and Korean technology should be used to advance Korean medical community and medical domain. And I ask for continued support on this and interest as well. Thank you. So you talked about the commitment and the direction the Korean government is taking. So although we have spent a lot of time, but we cannot go without giving the floor to Director General Kim. Yes, I am Director General of AX Innovation Department of HIRA. And we sometimes say AX and pronounce it as AK, as a expression of sometimes frustration. But when I listened to Professor of Daket, you mentioned risk of using AI might not be as big as risk of not using AI. And Professor Kim also talked about vacuum of consultation that can be created in the absence of AI. And that is a very refreshing expression. So 2 weeks ago, I went to this large clinic in Gangnam along with my son, and 20 questions were asked to the professor, at the general hospital during the 5-minute consultation, but the professor could not look at the face of my son because he was looking at the screen typing. So I was hopeful that in the future, maybe the ACP can be more engaged in the conversation, being freed from the documentation mission. So the AI virtual hospital of Tsinghua Hospital was really interesting. The hospital is virtual, but different simulations are done regarding different situation, different cases. So I got inspired. Maybe HIRA can create an AI-based virtual evaluation agency. So it can minimize the trials and errors we are experiencing, and it can also accelerate the implementation and execution. And Director Maldrop, I'm not sure if I'm pronouncing your name correctly, and you talked about AI as a object and AI as a tool. AI is something that we assess, and AI is also we are also using AI. So I looked at HIRA with that perspective and draw a distinction between the two aspects of AI. So AX innovation roadmap and the time frame everywhere has the same element. First is trust, second is human, and third is accountability. So at HIRA, we have 33,000 clinics to look at if there is exaggerated claims or fraudulent claims. And since 2019, for medical images, we have validated different private sector companies to increase work efficiency. And when we are conducting audit and legal related task, AI is harnessed to summarize and search different documents and regulations. But all of this also use basic common principles. AI just provide evidence or basis and organize the signal. And humans use those signals to interpret and make judgment and decide the outcome and be accountable for the outcome. So AX task was more streamlined with President taking office. So we have created key pillars and more systematic approach to governance. So first pillar is governance, and second is data infrastructure, quality and standardization, and the third is evaluation and monitoring, and the fourth is more systematic nurturing of talent to support all this, and fifth is all this should be aligned with social equity so that AI's benefit can be enjoyed by everyone. So public interest or public benefit for all with AI. So do you remember the movie Wall-E from Pixar?
So in that movie, the human is released from the duty of labor, and the machines are doing everything. But we are not envisioning that kind of world. Rather, with AI, our expertise can be expanded and strengthened, and the final responsibility should be borne by human beings. But we also have some concerns at HIRA. First, we have a nationwide public data, and we do have a very large amount of data, and therefore the privacy protection is really critical. Information protection is really critical for us. Any kind of the hacking incidents are not allowed. So nowadays the companies, they are already hacked, but they don't know, or they pretend not to be hacked, or maybe with a great fortune they have not been hacked yet. So we should not have a misunderstanding that our system is error-free, accident-free. Our system is so strong. That's why we haven't had any kind of hacking incidents. This is a real misunderstanding. And also the CMR data and EDI code, everything is connected, and that needs to be standardized. So for all the long-term care institutions, of course, they are covered by us, and also the whole public is also covered by the insurance, but the claim software are not harmonized yet. The softwares that each institution use for claims process is not standardized. And also we have to have the more budget for AI projects. So summarizing what I said, we have to think about why we have to use AI. The first thing that comes to my mind is to make my work more efficient and enhance the quality of public service. So I thought that that will be the initial reasons that we have to use AI. But then the president of HIRA gave me this same question once again. Why do we have to use AI? And if the AI cannot protect the public health, and if AI cannot protect or control the healthcare cost, then there may be no reason for us to reuse AI. So when claims are made on a real-time basis, everything has to be assessed so that the medical institutions can provide the appropriate care. And I think this is where AI's role lies in, and that concludes my comment. So thank you very much. Thank you for sharing the HIRA's concerns and also future direction. So listening to the three commentators' discussions and also four speakers' presentations, it gives me four keywords. Number one, trust or responsibility. And second is dynamic. So AI, in comparison with the paper-based system, the nature is very different and AI is very dynamic. And third is risk. So AI also has potential, a lot of risk. And fourth, so I think that's the most difficult question, that when human beings came up with the characters, languages, and also all kinds of communications could be passed down, and that actually stabilized the world. So I think that HIRA also played a key role in stabilizing the healthcare system. However, AI never stops and constantly changes, and therefore it's very difficult to adapt to it. So I'd like to ask a question to speakers. So Professor Muldrup, you gave us very practical tips, or you shared your practice, how we respond to AI. And so unlike the conventional static approach, AI is moving very fast and it creates a lot of problems or issues. So we have to have a proactive approach. And I think that in that sense, you gave us a lot of insight on that. So do you really think that the world is being changed because of the AI or the computer? So can you please comment on that?
I think it's already changing now. I think we see a change in the way we understand data. We see a change in the way we can interpret data, and also the knowledge we get out of the data because of the AI. I think we didn't have the opportunity to link all the data together in the same way as we did before. So now we see patterns, we see flows, we see mechanisms that we didn't see before. That makes us more clever, and will also make us take decisions that hopefully are more clever to our citizens. So I think already now we see changes. So I don't think we'll see dramatic changes in how we are as human with each other. I mean, AI has been around for long already. Park already mentioned driving the car. that is AI driven already. So and that's just become a part of our life. But I still talk to my wife when I'm driving. So it's not changing my life as such. It's making it more safe, at least when she's driving. So that's good.
네, 감사합니다.
So thank you very much. Yeah, so the changes are very rapid, and building institutions to respond to changes is very important. And so in the sense, I think that Taiwan actually made a great success with the unified system. So I would like to ask a question to the Taiwanese speaker. Yeah, so AI as a tool for regulation, but I think that each country has different situations. So maybe this can lead to another issue or another problem, but still we have to build the institutions, and AI has to be part of that. And I think that the Taiwan has one of the strongest institutions for AI response. So what's your view on on building institutions, and also how the dynamic changes can be reflected and properly adopted in the system?
Thank you for this wonderful question. As I mentioned, I think I'm humbled by this discussion. I do learn a lot from this fruitful discussion from ethics, risk assessment, and also AI tools. And before I share my view, I would like to share a little bit of what we have been doing on regulation AI in Taiwan. So last year, we established 3 AI centers inside the Ministry of Health and Welfare. And that is rare, as another speaker just mentioned. That is rare, but that has to be done. For example, we need to make sure that we do not violate our patients' privacy. We need to secure the cybersecurity. We need to have the transparency when we are using the sensitive data, health data from National Health Insurance Administration. And also, so we have a first AI center called Responsible AI. So that is to decide on what occasion that people could use this data, and what regulations that the institution or the company or the universities should follow or obey. That's a Responsible AI Center. But we do have the other 2 AI centers that many of you, particularly from the industrial level, might be interested in. They are the centers called Clinical Validation AI Center, because we, as a government, we try to help our Taiwanese company trying to make to get the clinical approval as quick as possible. So then, in the era of digital era and in the era of AI, as you mentioned, that the AI is driving the car already. So in this highly competitive world, we really need to speed up our industry. So in Ministry of Health and Welfare, we have the Clinical AI Validation Center trying to help all the company to register their clinical trial in Ministry of Health and Welfare, and to see their real world data, their clinical trial data, and to see whether the medical AI has effective or not. And then we have a third center trying to monitor the market surveillance about the risk. And as you know, that the way you develop the AI medical device, then it highly rely on what kind of data you put inside. So the data will change over time, particularly clinical data. So we will review the medical AI every 6 to 12 months. It depends on what kind of products that is. So we have the 3 AI center. One is to make the company or industry or the team accountable. First center, Responsible AI Center. The other 2 centers are for industry, for the medical AI team in Taiwan. So inside of the Ministry of Welfare. And then that is that part. And my part as the Director General of National Health Insurance is to do the data integration. As I mentioned in my talk, we have a lot of government data. We have treatment data in health insurance system. We have screening data in another department called Health Promotion Administration. We have social service data for those kids who are in need of help, for those patients who has been sexually or domestically experienced domestic violence, sensitive data. So now we are in the process of deciding what kind of data could be linked to our data to form a more fruitful data that trying to help each individual who are also in need of medical service and also in need of social service. But that is in the progress. We need to get a consent from our people, and then that is controversial. So that is some question that some of the issue that also I bring here in this platform and to see what other people might think. The way I mentioned that I'm a psychiatry by training, and then my background is addiction psychiatry. So over my 22 clinical career, I was seeing a lot of patients suffering not just from addiction, mental illness, but also from substance use or domestic violence. So as a government official, we are thinking maybe we can link the data and to find out those individuals who are in need of both social services and also medical services, things like that. However, if you want to identify them, you need their consent to say, okay, yes, you can link my data with my health services and also my social services. And so I do not have answer to that yet, and I do bring that out here in this platform that we have all the experts internationally and also from Korea. That's one thing. And second thing, I would like to say that I'm still cautious but optimistic about the development of AI. However, I do find that for some high-tech company, they identify their ethical issues faster than the government. And then they set the rules and say, okay, the rule is here before the government, in the United States particularly. And then the whole world will follow. I think that's the gray zone. That's, if you ask me, so that's something that I am interested to hear from the speakers on stage and also from the audiences about the regulation. As I said, we do have an AI accountable center here in Taiwan to regulate the medical AI device. But we do not have regulate all medical AI because everything is in the progress on global health stage. I think that so far I will end there. And thank you for that question.
예, 굉장히 구체적인
That was a very specific and insightful answer based on your diverse set of experience. And whenever I join this type of conversation, because AI or LLM is more specialized for language, AI is a very powerful tool, but it's not a trust machine. It cannot generate trust. And particularly LLM focusing on language, there is higher risk. Language can be trusted, but sometimes it can be deceptive. It can be a means of fraud. Sometimes people change their words all the time. So from this perspective, AI creates new set of risk we haven't seen before. So Professor Leung Park talked about new AI world, or new things can be done by AI, and you also expressed your frustration. But all of these new capabilities can engender a new set of risk. So I will give Professor Park some time to think. But again, data is different, regulation is different, context is different, everything is different for AI. So I would like to ask this question to Professor Duckett. So amid all of these backgrounds, so newly emergent opportunities and risks are something we are facing, and how can we incorporate this into this practice, everyday practice, to create, let's say, next system that can benefit from benefits and the trials and errors that we go through. So I will first give the floor to Professor Park and then Professor Duckett.
Yeah, so since we create something that does not exist, so I think that this could engender a lot of risk. So regarding this risk, we cannot avoid them completely, but we have to manage them. So first of all, we have to develop a scale to measure them. And also the consensus is very important. So we have to build a consensus on how much we can tolerate this risk, or on what level we have to regulate that. So we have to have that agreed framework. So that agreed framework, should it be created by AI then? Now, the Professor Duckett, do you have any comment?
I think the question is about, oops, sorry. Organizations, managers, countries vary a lot in openness to change, openness to risk, and I think what we need to be thinking about is how do we test what we want to do? Because especially when dealing with sensitive patient data, especially when dealing with healthcare, there are real consequences if we get things wrong, real issues for individuals. And so we don't want to, we've got to be careful about how we move from where we are now to where we want to be. And as a number of speakers have said, it is a very, very, I think one of your words was dynamic, and risk, of course, and trust. So what is the environment, what is the play space, what is the sandbox in which we test how we move from here to there? And that, I think, is what we need to be thinking about all the time. That is, how do we constrain our experimentation where it is a low-risk experimentation, but we understand that we want to set these goals, we want to achieve the benefits, we recognise that even though there are risks with using AI, there are risks with not using AI. So designing our environment to look to the future, but look to the future in a way where our risks are minimised.
감사합니다.
So thank you very much. I think that the floor also has questions. So we would like to open the floor for Q&A. And if you have questions, please raise your hand. And while you're thinking about the question, we would like to relay the question that we collected from online. So the automation bias for the regulation review, and how did you detect it? So we had a question like this. Expanding the question, I guess, so using AI, we also say that everything boils down to the average, and everything becomes similar, everything becomes mediocre. Then, however, you see that each country has different situation, different healthcare system, but with the AI, which is like a huge encyclopedia, do you think that will these differences be narrowed down and everything will be converged into a very similar thing? Or do you think that the changes are still dynamic and disparities will still exist? So the question is about how to detect automation bias. So if you have any answer to give, please. And also we will collect questions from the floor as well. So if you have a question, please raise your hand. But anyone to respond to this question?
Bias, I was going to answer about average and so on. Obviously, clinically, everybody around the world is the same. We're physiologically, we're similar bodies. Where there are big differences is in the context within which healthcare is provided. Some countries, most wealthy countries have national health system and universal coverage. The United States doesn't. Attitudes about extent of investigation, whether you are use less drugs or more drugs. They vary dramatically across countries. One of the issues we're facing in Australia is if you go on Google and you say, I've got these symptoms, Google will tell you, do X or Y, and that often is based on United States experience, which is not what we want to do in Australia. So the organisation I'm associated with, we are looking at to what extent can we make sure that the average answer or the United States answer is not what comes up on Google, but our answer comes up on Google. And it's those sorts of issues which I think we need to be dealing with.
예, 아마 의료 시스템이야말로
Right, so the healthcare system is something I think that has the greatest amount of the heterogeneity or diversity in the world. So with the advancement of the technology, I'm curious what kind of impacts we will see in the future. But anyway, do you have any questions from the floor? And also the panelists, you are also welcome to ask the questions. So we will collect some questions. Yeah, so I'm from the HIRA Incheon chapter, and I'm in charge of the review. But I would like to ask a very strange question before we conclude the conference. So I really learned a lot from today's discussion. But the question is how much I can really understand. So my question is, when the word AI will disappear? In other words, AI will be so pervasive and become commonplace, then we no longer have to use the term AI because AI will be taken for granted. So when do you think that will that day come? And when will that day come that we don't even have to use AI, the term AI at all? And after AI, what new keyword will emerge? So that's my question. So who will answer this question? 30 seconds. So I think that it is very likely, or 50% likelihood that that day will come in 10 years. And after that, maybe we will be talking about humanity. So humanity will be a new buzzword after AI. That's my. Okay. So the smartphone, the term smartphone was coined in 2006, but nowadays we don't really use that term. But the internet that was coined in the 1990s, but still is widely utilized. But the term AI, it refers to a particular intelligence. But I think that soon the universal intelligence will become artificial intelligence, and more than 90% of the global intelligence will become artificial. And when that day, then we no longer have to use the term artificial intelligence, rather we will describe everything as intelligence. Let me ask you a question to the Taiwan and the Danish case. So both of the societies are super A societies, just like Korea. So with regards to the demographic aging, so for the medical care, do you have any special AI initiatives to tackle the super aging, demographic aging of the societies? So in Denmark or Taiwan?
Well, I actually don't think we are a super aging country yet, hopefully not. I think we still have a quite a decent amount of new born and so on, so I don't think we are super aging. We, on the contrary, we do work towards the same perspective as Taiwan, that we want healthcare to get closer to your home, closer to you, and using AI to do that. So we are seeing a new reform on digital health in Denmark at the moment. So there's a completely new agency been put up called Digital Health Denmark, where we will see that a lot of the technologies that are provided to home care will, of course, utilize some kind of algorithm, whether or not it is based on AI, but in the future it might be. Why not? So I think it will become a part of everyday life in order to take care of people, to make sure that you can, for instance, maintain. You don't have to visit people to control if they're good or not. You can see that from their whatever Fitbit or whatever smartphone they are using, or smartwatch they're using. So I think a lot of remote data will be used to identify who is in need and who is not in need.
Thank you for the question. I think Taiwan is definitely a super age society already starting from 2025. And then we look at our health data as we cover everything. So for the cancer, it's difficult to manage. And we are trying to increase the investment in cancer treatment. However, as I mentioned for today's chronic illnesses, the medical expenditure grew so fast in a super age society. So we are trying to look at the data using AI first on diabetes, and then expand that to all the three highs. And then we will redesign our reimbursement system to lead our patient. For those who have high severity, go to the medical center. For those who have stable chronic illness conditions, please go to the clinics, and trying to help our medical healthcare system survive. And also to help our finance of our national health insurance to be more sustainable. So chronic illnesses in the age of super age society is definitely very important. And as I mentioned, it's super age, and also we are facing the low birth rate. So we do have a shortage of manpower, not just for nursing, but for all medical professionals in Taiwan. And so for whatever AI tools, they can help us to save manpower usage, to save some administration work, then we were definitely happy to embrace that.
네, 감사합니다. 혹시
Yes, we are over time, but do we have any questions from the floor? And one of the questions that was not answered is what's next? What's next after AI? So I would like to direct this question to Director General Chen. You talked about a family physician program, and you talked about gatekeeping. But socially, in fact, it is a very difficult topic to bring social consensus. And how did you build social consensus about that in Taiwan?
Very good question. Actually, we should definitely build a gatekeeper system directly. But we face a lot of challenges and different opinions from our Taiwanese people, because they could see all the specialties as much as they want, anytime they want when they make an appointment. So it's really hard to go back from a system with no gatekeeper system, going back to a gatekeeper system. That is why we use the digital infrastructure. So the way we do it is that we integrate all the program into the big digital platform. And then we will be able to see for one patient what kind of medical service this patient use, how much that costs, and then what happened, how many times of ED visits, and what's the consequences. And then with that, we will redesign our reimbursement system, and then to encourage them to go less to the ER and more to their family physicians. That is in our process. So politically, it's really challenging for a healthcare system to go from a system with no gatekeeper at all to a gatekeeper system like Singapore. However, we are trying to tackle that problem with our digital infrastructure again. Thank you for your question.
예, 시간이 되었는데.
Yes, we are out of time. So, but still, the intention of the question is surprisingly, the patient access is almost granted without limit. So they can see different specialists anytime they want. And of course, programs like Gatekeeper and because of the sentiment the Korean people has, gatekeeper system is very difficult to build in Korea. Because in Korea, anyone can go to any hospital whenever they want. So limitless access is granted. So the key to that question was basically a social consensus. But again, the theme is AI. So AI as a tool was discussed, but Heidegger in the past talked about the relations between tool and human. Sometimes we do not even recognize we are holding a pen or a pencil when we are writing. So it's a disappearing tool, the tool that is almost non-existent in our awareness. So AI will be like that. AI will be embedded in everything that we do in the future. And I don't know what will be the next thing. Maybe after the seminar, we can think about that question. If there is any further question, maybe we can entertain one or more questions individually. So once again, I would like to thank all the speakers and panelists. And with this, I would like to conclude the panel discussion. Thank you very much.
유익한 토론을 위해서
So I would like to thank everyone, the moderator and panelists and speakers. Why don't you give them a round of applause once again for their great participation. And this will conclude the 2026 HIRA International Symposium. Before giving you the final remark, I would like to make a housekeeping announcement that we are conducting the satisfaction survey. So please scan the QR code to have access to the survey, and your feedback will be highly appreciated for a better conference in the future. We'll also give you the coffee voucher if you fill in the survey. So please, your cooperation will be highly appreciated. Once again, thank you very much for joining us and remaining with us till the very end despite your busy schedule. I sincerely hope that today's symposium will offer us with an opportunity to lead innovation in healthcare in this era of AI.
the way for AI-driven healthcare innovation. Thank you very much for your active participation. 여러분 안녕히 돌아가시고요. 저는 지금까지 아나운서 박세정이었습니다. 고맙습니다. 심사평가원 직원분들께 안내 말씀드리겠습니다.